I want you to put up the first slide for the.
Well, Shari, can you start your can you start Monojit as a moderator?
Yeah, I need the A slide. I need the first slide, which has got all the details so that I can help from me. So yeah, he started sharing the screen. Okay, that's all. No. Let's go for start from the beginning. Okay, so Dr. Subhash Ray, I'm starting, right?
Okay, yes.
Okay. So good afternoon, everybody. Good afternoon, members and fellows of the Royal College of Physicians of Ireland and all physicians from Kolkata and throughout India and even from UK who have joined. We are meeting after a very, very long time. During the COVID pandemic, we were meeting about every month on by webinar. And I think last year we stopped that. And then it is the first time, I think after a long time, we are joining with a webinar. And we have had a lot of interactions with each other. But I think the key basis of the RCPI is that to further education, and that is why webinars are part and parcel of our forum. So with this, Debashish, can you show me the first slide, please? I would like to invite all the speakers and the chairpersons. So I would first call upon Dr. Subhash Ray, who's the chairman of the Indian chapter and the regional advisor for RCPI, to say a few words before we start today's program. Over to Dr. Ray, please.
Good afternoon, everyone. It's my proud privilege to talk about the Royal College of Physicians of Ireland, the oldest institution in the world. And we, the Indian chapters, since inaugurated in 2005, have been actively involved in organizing the MRCP examinations and also doing academic activities within India and neighboring countries by alone or in association with the organizations and institutions of India. And we have been going strong until the COVID situation came and blocked us all over. And then after a while, we resorted to webinar, and we had a successful webinar, about 10 webinars from 21 to 22. And then we had a pause. Now we are restarting all over again today. And let's start with the first speaker. Without further conversation, I would request Dr. Deepika Kedia to start. Before that, I would like to say a few words that the inflammatory bowel disease consisting of Crohn's disease and ulcerative colitis is one of the commonest gastrointestinal disorders of the world, predominantly in the Western world, in Europe and America, and about, to my knowledge, is about over 6 million per year, and over 80 million adults. And contrary to popular belief, the inflammatory bowel disorder is not uncommon in India, but mainly ulcerative colitis, for relatively less of Crohn's disease, mainly because a number of things. First of all, is if it particularly affects the small bowel, it's difficult to access with our limited resources, and it's time-consuming, expensive tests to confirm the diagnosis. Therefore, but as we are going along with the last decade or so, more and more cases are coming up, and we keep our eyes open and look for the cause, with the indications. If we have history and clinical finding, we'll find more cases. But my statement may be quite backdated, as Dr. Deepika Kedia just coming back from an update in inflammatory bowel disease, and she will enlighten you with all the recent events and also her own thoughts about this Crohn's disease. So without further delay, over to Dr. Deepika Kedia.
Thank you, Dr. Ray. I would say that it's become quite common now in India as well to have Crohn's disease. I'm just going to start screen sharing. Right. see my slides?
Yes.
Okay, I'm just starting. So my topic is Crohn's disease, and it has become one of the most commonest disease out of ulcerative colitis and Crohn's. We are seeing more and more Crohn's disease in our country now also, like the Western world. So it is an idiopathic chronic inflammatory process that can affect any part of the GI tract from mouth to anus. And it was described in 1932 by Professor Crohn's and described as regional ileitis. It has been described 20 years prior to that, but the disease has obviously been named after Dr. Professor Crohn's. A Polish surgeon has also described the same disease in 1904. So it is a continuous or patchy disease, a condition which symptomatic relapses and remissions, autoimmune disease, and along with the inflammatory bowel disease, along with ulcerative colitis, it forms what we call IBD or inflammatory bowel disease. Then you have indeterminate colitis as well, which is neither ulcerative colitis nor Crohn's. So first thing is the differential diagnosis of Crohn's disease. You can have terminal ileitis and acute appendicitis, ileocecal TB, which is very, very common in our country, and infective reasons also. Same colonic disease also, you can have ulcerative colitis because you can have Crohn's colitis, but you can also have ulcerative colitis. And very common in our country is also infectious colitis. So we have to keep this in mind. We can't be diagnosing every single patient with Crohn's disease. The incidence of Crohn's disease in India, most north and south says males more than females, but in central India, they have found there's no difference. In incidence in India in the first 10 years of life is 3 per 1,000, but as we grow older, the incidence increases. So overall incidence is around 3%. And we found out that large migrations of males from villages to cities and more frequent visits to the hospital by men in the cities is causing men to have it more than women. Minor disease in India, 1/3 have chronic active disease, half have relapsing disease, and 4% only in India at present are needing surgery. But the risk of colorectal cancer remains the same as the West, 1.5, 7.2. And in the third decade of the disease, like if you have the disease for 30 years, it is nearly reaching 25%. And major burden in our country is children, adolescents, and teens. And we have this, task of differentiating it from TB. But the overall incidence, actually, the diagnosis is more in the on 40 years of age. First degree relative, you have a 10% chance of getting it. If parents have it, then the children have 30% chance of getting it. But if there are twins, then they have up to 50% chance of getting it. And in our country, mean diagnosis age is 40 years. There are a lot of environmental factors in play because in Canada, they've seen that if Indians are traveling to Canada, the first generation have a very low incidence of Crohn's, but their children have the same incidence as the localites, the Canadians. So that means there is a huge environmental factor in play here. Extraintestinal manifestations in India at present is found to be low. The risks in India is westernization of Indian diet, improvement of hygiene and environmental condition is actually a risk. Genetic predisposition, which is found all over the world, is not seen in India. Smoking increases Crohn's disease. But see, we have 65% population smokers in India. We still have a low incidence compared to the West. Food rich in animal protein, fat, and meat is a risk factor, and excessive tea and coffee. And if you have a positive family history, in India, it's still less. 10 to 25% people will get it. But in the West, obviously, the percentages are much higher. Rural dwelling is called a risk factor, but I actually see less patients in India. And I'm sure Dr. Ray also sees this less rural patients getting Crohn's. 12 months breastfeeding is protective, and so is high fiber fruit and vegetables. But higher education, professionals, annual income more than 100,000, and a history of appendectomy are all called risk factors. In India, if you see, protective is North India is better toilet facilities and use of a separate bed. But safe drinking water is again, found as a risk factor in India. In South India, they've studied 200 Crohn's disease patients in Vellore, and they have found that if you are in the village and you're rearing cattle and you are having fish, then it is a protective factor. So if you see from North and South India, they're getting very different, results from the studies. But what we have found from the gut microbiome is that there's heightened mucosal adherence of E. coli in the colonic Crohn's disease, and use of antibiotic decreases the odds of development of Crohn's disease. So location now of Crohn's disease, in different studies, Dr. Makharia and the team, Dr. Vineet Ahuja and all, they have found that 182 patients were studied in 3 different centers, and IBD national survey was done. Terminal ileum was found to have 1/3 of the patients. Colon was, around 40 and 30 patients, and alloconic together put in was up to 40 patients, 40%. So in India, if we see colonic is the most common area where we get Crohn's disease. Perianal, if you see, is a big number, 17%. And I've just come back from this conference where they're saying that patients who have recurrent perianal fistulas actually have Crohn's disease. So if they've been seen by the surgeons once and they're getting it again, please think about Crohn's disease, because these patients will actually develop GI symptoms 3 to 5 years later. So we have to keep in mind recurrent perianal fistulas with no GI symptoms can be Crohn's disease. Small bowel, 70 to 80%, and terminal ileum gets affected first. Small and large bowel in India, 50%, and only large bowel, only 20% of the patient. So if you see on the left, you have a normal looking transverse colon. Then you have Crohn's, where you have the typical, lineal ulceration and very inflamed mucosa. And on the extreme right, you have the cobblestoning of the mucosa. So this is, if you see cobblestoning of the mucosa, you can be rest assured that you are actually dealing with Crohn's disease. Now, we have to take a very detailed history from the patient, because by the time you finish taking a history and examination, you should more or less be sure that you are looking at Crohn's disease. So you have to take a family history of Crohn's or ulcerative colitis, all other autoimmune disease. We have to take a very detailed food intake, and I will tell you later on why, because we have to find out when the patient is eating and what the patient is eating and what amount of fine flour they're taking. Fluid intake we have to take, and movement of the bowel. Loose, ill-formed, constipated. What does a patient mean by constipation? Whether the patient has fecal incontinence. Nocturnal bowel opening. If the patient has nocturnal bowel opening, there's only two diagnoses. Either the patient has an infectious event happening, or this is IBD. This cannot be IBS at all. Mucus in the stool, incomplete defecation, a feeling of defecation all the time, and increased gastrocolic reflex. And also blood in the stool, fresh or separate, nausea, vomiting. Then we have to take a very detailed history of where the pain abdomen is, where does it radiate, when does the patient get pain. Also, a lot of patients will say they have chest pain, and you will find out that they actually have pain in the costocolumnar junction. So we have to take a detailed history of chest pain. A lot of patients complain of bloating. So we have to find out when are they getting the bloating, is it causing pain abdomen, and how is the bloating getting released. And a lot of patients get bloating with shortness of breath after eating. So we have to take that history, and mental stress, because when they have mental stress, they get more symptoms. Then excessive burping, excessive PR gas, fatigue, tiredness, joint pains, and muscle pain is a very, we have to take a detailed history. And pain in the soles of feet and palms of hand, because they get fasciitis, low-grade fever and mouth ulcers. Sleep pattern, some patients will see we are sleeping a lot. Some are saying we cannot sleep at all. Weight loss, how many kilos? But you also have the other group of patients who actually have weight gain, because now we know there's a leaky gut syndrome, and there's a whole lot of problems which they get actually more weight gain. So when the patient is already exercised, in spite of that, they're getting weight gain. Frequent colds or coughs, because we know sinusitis is associated with Crohn's disease. Decreased appetite and allergies, all kinds of allergies. Now in the history, we are also asking for any lesions on the skin, chin, and elsewhere, swellings anywhere in the body, and any weird symptoms the patient tells you. We have to note that down. Sweating episodes and draining feeling or clouding of vision, near blackout, fainting episodes with loose motions or with pain abdomen. So we have to think of IBD. And if they are getting frequent loose motions without vomiting, with dehydration, and are needing hospitalizations very frequently, we have to think of Crohn's disease. Frequent vomiting, acidity, burning, retrosternal, needing antibiotics frequently, they become better, again they become unwell, and headaches with other upper GI symptoms like bloating and acidity. And it affects the lives actually. Headaches really affect the life. Then red eye, irritation in the eye, because these are the extra intestinal manifestations, and frequent UTIs. When we are coming to examination in a patient, we have to look for pallor, because they're anemic frequently, edema, lymph nodes. Obviously, we are checking their BP, heart rate, temperature, oxygen saturation, because they can get pulmonary fibrosis, weight, height. Erythema nodosum, we are looking for on the shins, pyoderma gangrenosum, wheals on the body, all the joint swellings, and also sacroiliac joints, because these are very commonly affected in these patients, as well as small joints of the hand, and whether they're ill-looking or not. Erythema nodosum, I just want to tell you, 55% patients will have no clear cause, but TB and Crohn's are the commonest causes for erythema nodosum, and this is what it looks like. These are violet color raised bumps on the shin. These are nodules. They disappear by themselves in 4 to 6 weeks. You don't have to do anything about that. But we have to keep in mind if patients have erythema nodosum, are we dealing with Crohn's, are we dealing with TB? Pyoderma gangrenosum are again seen on the lower limbs. They're neutrophilic dermatosis. They're usually seen in Crohn's disease, ulcerative colitis. So we have to keep in mind if we see some lesions like this. If you see any lumps in the abdomen, we have to feel for any guarding and deep palpation, especially look for appendix, gallbladder, because patients can have stones with, Crohn's disease, any big lumps, tended areas along the small gut, colon, and obviously ureteric stones are also a big part. Patients do, there's an association of ureteric stones with Crohn's. So we have to keep that in mind. The liver size, I've seen a few patients who have liver abscesses, which was not due to amoebic liver abscess, and that was due to Crohn's. So that was the first presentation. And then when we treated the Crohn's, the liver abscess also disappeared gradually. Even the subcostal margins, please examine, because patients are commonly very tender there, and the costochondral junctions also. If rectal bleeding, please check for hemorrhoids. A lot of patients do not have hemorrhoids, but they have fistulous opening from which in the perineum, where from that passing pus and blood. So we have to keep in mind that anal fistulas or rectal fistulas are very, very common. Here the chest, pleural effusions, fibrosis, check for tenderness, like I told you, ribs and costochondral junctions. CVS, heart rate, bradycardia, because sometimes they are also hypothyroid, or if the patient is exercising a lot. If they are having too much diarrhea, obviously we can get low BP. A lot of patients have vitamin B12 deficiency, so they'll have pins and needles, and also a low power in the muscles because of just deficiencies. And all the joints and fascias, like I've just told you, for alluding out to rule out fasciitis or sacroiliitis. And I would suggest we should all look at old reports, because doctors don't tend to spend their time looking at old reports. Many times, if you just look at the old reports and look for anemia, neutrophilia, high eosinophil count, high CRP, low albumin, multiple deficiencies, abnormal liver function test, you will actually know the diagnosis of these patients from the old episodes when they're having similar episodes in the past. Ultrasound abdomens, you can actually see intestinal wall thickening, old barium meal follow through, MRI abdomen and CT scan abdomen will all give you diagnosis if they've already had it done in a previous episode. If they have eye prescriptions for uveitis, iritis, etc., and they have GI symptoms, then you can be sure that you're looking at IBD. We do a complete hemogram, ESR, CRP, LFTs, because see, your patients may have NASH or your patients may have autoimmune hepatitis. If the globulin is high, we have to consider autoimmune hepatitis, and we have to do a total IgG, IgM. Thyroid, obviously, because a lot of patients have hypothyroidism, creatinine, and then we're checking, malnourishment like vitamin B12, D, calcium, folic acid, iron studies, and some of our patients are diabetics or hemoglobin A1C. I routinely check for wheat allergy, because a lot of patients do have wheat allergy. So you're doing a TTG antibody to start with, and then you can always do further tests if you need to. Then we're doing IBD panel, which includes a fecal calprotectin, ASGA, and the ANCA. So ASGA is IgA, IgG. It's very easily available, and this panel is quite reasonable in India. Fecal calprotectin is high in infections, in cancer, as well as in IBD. So if you have a high fecal calprotectin and you've ruled out an infection and a cancer, then you can actually use a fecal calprotectin to monitor disease activity. So if your patient is becoming better, fecal calprotectin starts coming down or comes down to normal. If you're doing routine stool, that is fine, but occult blood in stool should not be done till your patient is vegetarian for 3 days, because I have got too many times with a report which the patient brings to me saying occult blood is positive, and the patient tells me the previous night I've had a lot of red meat. So you should, if you have a positive occult blood, please repeat the test after the patient being vegetarian for 3 days. And if the patient is having huge amounts of loose stool, then stool biofire is available, but that is very expensive. So we have to see whether the patient can afford it or not. If the patient has joint pains or fasciitis, please do HLA B27, ANA, anti-CCP, uric factor, and rheumatoid factor. Usually our patients are seronegative arthropathy, but before you send the patient to a orthopedician or a rheumatologist, they will ask for these tests. If the patient has fever, do usual blood cultures, typhoid, malaria, blood film, but also keep in mind they can be having a acute episode of a flare-up of Crohn's. Abdominal X-ray for your multiple fluid levels if you have intestinal obstruction in the patient, and obviously ureteric stone. Ultrasound abdomen, I have got caught out 3 times with young girls coming with their parents. They were pregnant, and I cannot ask them whether they're pregnant or not. And I am looking at, they had all the symptoms of Crohn's disease or ulcerative colitis, and when For some reason or the other, we did an ultrasound abdomen or even an MRI, MR enterography, we found out that the patient was, advanced pregnancy. So I think we should just do, an ultrasound in all our patients, young girls especially, because they will not tell you that they're pregnant, and then they will, you unnecessarily get caught out with these patients. Check the gallbladder for any stones, ureteric stones, lymph nodes, and especially thickening of gut wall. I'm going to talk about this later on. MR enterography is very, important test. It gives you all the strictures, wall thickenings, ulcerations, fat creeping, and especially all the fistulas, common as being rectal. You can even do a CT scan with oral or IV contrast with strictures, wall thickening, abscesses, and fistulas. And I've just come back from this meeting where the newest modality is intestinal ultrasound. It is the same ultrasound machine, but the probe is different. You can actually see the bowel wall thickening. You can see the bowel wall stratification, and you can even do the color Doppler flow and see if in an inflamed intestine there's a increased amount of flow to the gut. You can see these. You can see strictures there. You can see abscesses. You can even see fistulas. And in India, it is not yet started, but they're going to start in November training for this in India. So I hope that I can do this training and be able to do this in our own chambers. You can actually do, and this is going to become the first line. Intestinal ultrasound will become the first line even before you're going to do an MR enterography or CT scan. So this is very easily done. It's going to be very affordable for our patients, because a lot of patients cannot afford MRIs and CT scan. Even in our country, it's quite expensive. So this is becoming common now. Upper GI endoscopy, we are going to take distal duodenal biopsies for each pylori and from all abnormal areas. We have found a lot of times patients get upper GI cobblestoning also, which I showed you before, in the duodenum as well as in the in the stomach. So we take biopsies. Colonoscopy, biopsies from all inflamed area, loss of vascular pattern, cobblestoning usually in the ileum or even in the colon. We have to remove all the sessile polyps and send for cultures, and also check strictures. I have not written here, but we should also do a capsule if we have to look at the small cut, small intestine. The first therapy they are saying do capsule. If your capsule shows a stricture or it shows lots of ulcers and you want to see, or a polyp and you want to take biopsies, then we go on to do small bowel enteroscopy. If you find colonic or ileal ulcers, it is very important, especially for the ileal ulcers, to do biopsies for AFP stain, TB, gene expert, TB bacterial culture, and obviously send it for histopathology. And for rectal fistulas, obviously the culture of the pus and MRI to see the track of the rectal fistulas, and now intestinal ultrasound. If your patient is short of breath, even if it's with bloating of the abdomen, I would still do chest X-rays, ECG, and echo, because you don't want to miss a cardiac cause of these symptoms. If the patient is above 60 years and you're doing endoscopy and colonoscopy, you need to do it anyway. So might as well just do it if the patient is complaining of a lot of shortness of breath. And we have to make sure that the patients are not on blood thinners before we start doing endoscopies. Extraintestinal manifestations, usually 40% patient will have one extraintestinal manifestation, 20% might have more than one. But this is the Indian record, Indian data. Most frequently, you get peripheral arthritis and ankylosing spondylitis in 18% people, and up to 10% is ocular. Then you have, I don't know, for some reason, females, Hinduism, severe disease, and steroid is supposed to be linked with extraintestinal manifestation. There's no explanation given for this, but it is said that it is associated with more extraintestinal manifestation. You have to tell the patient that they have Crohn's disease, and you have to tell the family also that long-term therapy will be needed. This is a waxing and waning disease. Extraintestinal manifestation is possible. Make sure that obviously all the family members are there when they are telling the patient this. You have to tell the family and the patient what to expect and when to contact a doctor. Medical insurance, many patients, they don't tend to increase their medical insurance or coverage. They have to be told that they need to continue their medical insurance, because this is more or less a lifelong disease, and patients can get intestinal obstructions, they can get flare-ups, they might need hospitalizations, they might need surgery. So I always tell my patients, continue your medical insurance. Then for the prescriptions, the first thing is the patient should be exercising regularly. They should be doing yoga, some sort of meditation. If they don't want to do yoga, some sort of de-stressing meditation, pranayam. It really helps our patients. And if you tell them to do this, I have seen a lot of my patients really improve, because if they're regularly doing some sort of de-stressing, activity every day, their autoimmune disease will become better, because a lot of mental stress plays a part in this. Avoid dairy, meat, wheat, preservatives, emulsifiers, sweeteners, food color, and sugar. I've just come back from this conference where they've said that emulsifiers and preservatives and even artificial sweeteners are one of the main causes of inflammation in the gut. And also wheat. Wheat, they're saying you can take alternative to wheat like jowar, bajra, maize, all these other things are better because wheat is quite pro-inflammatory. Eat healthy food like lots of vegetables, fruit and yogurt. All deficiencies like we've seen has to be corrected. If your patient has anemia, please check occult blood in the stool. If the patient is occult blood negative, then if the patient is iron deficient, then please, you can give iron infusion, because very few patients actually can manage to take iron tablets and then they don't absorb it. Vitamin B12 and folic acid supplementation, vitamin D calcium supplementation, and for binding loose stool, probiotics. And I even tell them to have raw papaya and banana if they're having a lot of loose stools. And stop smoking is very, very important. They cannot have Crohn's disease and they can't be smoking. If your patient has hard stool or no stool, we have to first find out what amount of water are they drinking. Everything is not IBD. Sometimes they're just drinking very little amount of water, or they're not, they're eating too much fiber, or sometimes no fiber. Oral iron causes constipation, so we may have to stop it. And then obviously we add in ripe papaya, bananas and bale. So this actually sometimes helps them to have normal stool. It is not always Crohn's disease which is causing no stool or hard stool. Mesalamine is the main drug which we use, 3 grams orally to up to 4 grams. We start with 3 grams. You can give suppositories for only proctitis. Enemas will go up to the rectal to the sigmoid area, and for budesonide is locally acting steroid. So controlled release is absolutely released in the entire intestine. So you have to give 9 milligrams per day at least for 3 months. But the MMX variety is actually, it needs a pH of 7. So it gets released in the ileum and then it works only in the colon. So you can only give budesonide MMX only for colitis. A lot of patients will not become better with budesonide. If they have moderate to severe disease, then we have to give them prednisolone, or we have to give them, if they have contraindications to prednisolone, then we have to give them biologics. So we start between 40 to 60 milligrams per day. There are a lot of side effects of steroids, but if you have to give it to the patient, you give this dose for 1 month and you start reducing the dose after that. Azathioprine obviously is steroid sparing. We start with 2 to 2.5 milligrams per kilo per day, but it's always best to start with 50 milligrams per day and gradually increase it every 2 weeks, that the side effects are much less. Extraintestinal manifestations, if your patients have, you have to refer them to your eye specialist friends, your orthopedics, rheumatologists, chest physicians. And for severe joint pain, we need the help of orthopedicians out here. They need local heat, exercise, Predmet also. They're given 16 milligrams twice a day. And even azathioprine really helps. Biologics, there are 4 of them now available in our country. In fact, 5. One is the anti-TNF. You get IV and subcut infliximab. So for severe disease, we are still using IV and subcuts infliximab or adalimumab, which is subcut. And then you have antibodies to integrins, which is vedolizumab, and you have antibodies to IL-12 and 23, which is ustekinumab. Now, vedolizumab it does not cause patient to have a TB flare-up. So if you're worried about that, you can give this drug. And oral JAK2 inhibitors, which is an oral drug, so it is very easy to use. So Vatinib. Now, all these drugs are available in our country now, but Vedo is around 71,000. Osteokumab is around 1,50,000. So it is extremely expensive. So we have to be very careful who we give it to, because a lot of patients do not have the money to spend money on the biologics. So then in those patients, we might have to use a combination of steroids, budesonide and mesalamine. A lot of times when we're giving infliximab, you have to give azathioprine along with that. You don't only give infliximab. You have to rule out any occult TB before you're going to start any biologics or AZA. So you have to do that workup, and all viral infections we do. And since if you're going to give your patients steroids, then you are worried about osteopenias and osteoporosis. So you have to give zoledronic acid or denosumab. Zoledronic acid is once a year. Denosumab is subcut every 6 months. You have to vaccinate your patient, again, hepatitis A, B, pneumovax, influenza, and herpes zoster if you're going to use ustekinumab, because it causes, that is one of the side effects. These are very important, because if you're going to use, steroids, or if you're going to use azathioprine, if you're going to use biologics, your patients should be vaccinated. You do not want these infections happening to your patients later on. because you are immunosuppressing them. Now, the take-home messages is Crohn's disease has become very common in our country. So you have to, as a doctor, counsel the patient and the family for long-term therapy. Early diagnosis and early aggressive treatment is very, very important to avoid complications later on. Educate your patient and the relative about what to expect, and please ask them to read about it. Huge amounts of information is available on the internet nowadays. And American Gastroenterology Association has at least 50 pages of information for the patient. Life gets affected, especially for children. So they need a lot of psychiatric counseling, especially for children. Mental stresses causes flare-up. So you have to be careful that when school students and college students have their exams, we have to support them at that time, because I have a lot of patients who are school students and college students, and just before the exams, they get a flare-up. Now, in jobs or businesses, patients, have mental stress and then they get a flare-up. So we have to support them with counseling, medicines, yoga, or meditation. They have to drink safe water, eat safe food, and dahi is very important. Yogurt every day. Avoidance of maida, and there's a lot of benefit which is seen from gluten-free diet. Now, in this conference, they have shown that if you have a diet which is, you remove all the inflammatory component from the diet, it can heal your IBD patients. And they have shown that over a period of 6 to 8 weeks, steroids and diet have the same results. So if your patient says, I don't want to have steroids for 8 weeks or 12 weeks, we can put them on a diet and they will have the same results. They have to be strictly on that diet. They have to maintain that diet. They will be, they have the same healing as a person who's taking drugs. So this is becoming a very important area in IBD, and we have to spend a lot of time so that we can counsel the patients on this. Patient needs to be seen regularly. This is very, very important. Thank you. Dr. Ray, you're on mute.
Sorry. Hello. Now,
yes, we can hear you.
Now, I said, thank you very much for such a comprehensive enlightenment of the Crohn's disease. And you've covered everything, including the current methods. I'm particularly impressed by the recommendation with the non-pharmacological methods, which is probably should be adopted by patients, and which is not so easy in practice, because as we say, medication is easy, meditation is not, which is
yes.
probably should be reversed as far as we can. Now, I have a number of questions, but before I do that, in the
yes.
next 10 minutes, I think I would ask the others to ask a question first, then I will do that. So can you ask questions from the floor?
Dr. Kedia, Dr. Vinayak Xavier.
Yes, sir.
Yeah, my first question would be that you mentioned about stress being one of the provocating factors or making Crohn's worse.
Yes.
This being an autoimmune disease, we know stress, what it does to cardiac problems, because we know the pathophysiology as well, because stress hormones are something which is not good for heart.
Yes.
So how do you explain stress as a provocating factor for an autoimmune disease like Crohn's?
I think it probably follows the same route, because I think a lot of stress hormones are increased in the body. A lot of cytokines come into play. I think and the oxidants, I think everything is released because of stress. Because routinely I've seen my college and my school students, before an exam, they have the board exams tomorrow and they land up in hospital the previous day with, severe pain, abdomen and diarrhea. And they've been fine before that. Then I've had patients who are about to get married and they have landed up in hospital because of mental stress. So I think it's the same thing which causes the cardiovascular disease. I think they have not, actually looked at all the markers. But what I feel is the stress hormones causing oxidants, causing cytokines being released in the body. And that is causing the flare-up of Crohn's, so through that method.
Yeah, I think as Dr. Ray just mentioned, the non-pharmacological methods are equally important and probably very underplayed compared to the medical methods which we follow. So I think in our practice, particularly in this kind of disease process, and the non-pharmacological methods of diet and stress reduction should be one of the areas which we really need to focus on.
I mean, I tell all my patients, if they want to do some sort of meditation, I tell them do it every day. And I have seen that some of my patients have actually managed to come off medication because they are doing, they're looking after their diets. They didn't want to take medicines for the rest of their lives. So they're doing meditation every day. They're doing yoga, pranayam, and looking after their dads. So a lot of my young patients, young women especially, they have actually come off all medication and they're only doing this and they're perfectly well. Even before the studies came out about that, they're already doing this.
I think the meditation bit is very, very important, because I think a lot of people, we meditate, but we think of something else in life. So
yes,
I think while we are meditating, we should be really focusing on a particular issue. Thank you.
Thank you, Dr. Dev.
You think you have a problem with the men with meditation, right?
Absolutely.
Men are following.
Yes.
So I think any other question before I say something?
There's one question from Dr. Mukhopadhyay. Yeah. So Dr. Monojita, we have not seen actually, there's no, see, diabetes is actually part of autoimmune disease also in some patients. Patients who have hypothyroidism and diabetes, we say it's actually an autoimmune disease. So those patients will definitely have more Crohn's disease also, in incidence of Crohn's disease. So my patients, especially middle age and above, I see they have hypothyroidism, they are diabetic, and they have Crohn's. So yes, if we think it's an autoimmune disease, yes, the association is much more. We do see patients who have these combined together. That is why in my list of investigations, I have put in hemoglobin A1C, because some patients don't even know that they are diabetic. Like we actually make the diagnosis for the first time.
Thank you.
Thank you.
I have a few questions, if you don't mind.
Yes, sure.
Thank you first. Thank you so much, madam. This was a very, very comprehensive talk.
Thank you, Gopal.
I absolutely agree with Dr. Subhashaji Ray sir when he said that the stress of this talk, especially on the non-pharmacological methods, it's so extremely important. And thank you so much, madam. Especially, I love the bit where you said, even you spoke about the insurance policies. But coming to my questions, first one is a very small question. It's just an observation, really. When you said, with regards to your patients that you found to have been pregnant at that time, you mentioned ultrasound. Would there be anything precluding an urine pregnancy test?
You think you can do that in India? If you tell your patients who are coming with their parents that I want to do urine for pregnancy test, they'll kill you. You cannot say that. You see, you are working in UK. There, a 12-year-old, 13-year-old will say, I have no issues in doing a pregnancy test. In fact, in NHS, before you are actually giving IV antibiotics, we actually do a urine pregnancy test on the young girls in the ward, especially when they come through emergency.
It's more regional rather than...
so in India, I can't even ask the patient, young girl sitting with the parents that you think you can be pregnant, because the family is going to get so angry with you. So it's easier to do an ultrasound abdomen and say, I'm looking to look at the, because I mean, all these 3 patients came with their families, with their parents, and they were pregnant. And then they're telling me, I don't have a boyfriend. I said, oh my God, wonderful. You don't have a boyfriend and you become pregnant. So it's, and one patient actually on the MRI, we saw 20 weeks pregnant fetus. And, she actually has not shown that report to her mother. She told me to change the report. I said, I can't do it. So she herself changed the report, because her mother can only read the report, because the radiologist refused to change that. She changed the report and she showed the changed report to her mother. Then with a friend, she went and got her herself aborted. So all this happens in India and we have to deal with all this.
I haven't come across such patient. But anyway,
the more clinically relevant question that I had really was in the more recent context of COVID.
Yes.
So I was, when I see some hematology patients, I've seen certain problems like ITP and stuff being particularly resistant in people who have either had COVID or have had a recent COVID vaccination or even a booster. And since these immune-related hematological problems are, of course, uncommon associations of inflammatory bowel disease, and again, of course, more common with ulcerative colitis, probably.
Yes.
But would you say, in the context of COVID and its vaccines and boosters, have you seen any increased preponderance of these inflammatory bowel diseases, which I understand has an immune basis?
Yes. So, a lot of patients who've had COVID actually infection recently, like if they've had it in the last 3 months or 6 months, or even during COVID times, when they're taking a lot of painkillers because the fever was not coming down, or they had a lot of body aches and pains, joint pains also. I have seen two things. One is while they're having joint pains, they've had some GI symptoms in the past. During that time of COVID, they are having, huge amounts of GI issues, diarrheas and pain abdomen.
Yes,
so that
yes,
was one group of people which they already had GI symptoms, but they were underplaying it. It wasn't very bad. But the moment they were giving a lot of painkillers during COVID, when they had the infection themselves, then they had a flare up of their IBD. The second group of people are who are absolutely well, but they had a COVID infection, a mild COVID infection. They recovered from that. After that, in the following months, they're having a lot of GI symptoms. And, these patients are, I would call them COVID-induced, mild inflammatory bowel disease. You treat them for 3 or 4 months or 6 months and they completely become well. After that, usually they don't need medication. So you only need to support them for 3 to 6 months.
Right.
So the more they go out of the, the episode of Crohn's, they become, episode of COVID, they become better. But see, only with the vaccination, I have not seen patients who have had only the vaccine and no infection ever.
Yeah.
I have not seen an increased incidence of IBD. It's only when they've had,
or may not be incidents, but even maybe a sudden flare close on the heels of a recent vaccination or something of the sort.
We have not observed that actually. I've seen it more with COVID patients.
Okay. Thank you. Thanks a ton.
Thank you.
Thank you so much.
Any other question? I think if we allow time, there will be plenty of questions coming. But I think perhaps I should make a few comments and ask a few questions before we can end this talk. First of all, I think the pharmacological therapy that she mentioned, one should remain, that it starts from the basics.
Absolutely, and then we'll build up.
Today, mesalamine is the first and does majority of good things. But there are in this country where the pharmacological plethora is so much, every week there's a new company, and now with this JAK inhibitors is coming into being with tofacitinib in the market. Every week there's a new company bringing tofacitinib. But don't get carried away with that.
It's very expensive.
This is expensive, not that expensive, too much. But this is not the first line. This is not the second line.
No, it's not the first line. So we have to be careful who we prescribe this drug to.
After all this, the step-by-steps that she mentioned, this comes third line probably. That
is why I put it at the end.
Yes, that's right, third line. The last, I said that I didn't see, you mentioned about the endoscopy and capsule endoscopy, which is, because you mentioned so much about the new stuff, which is probably coming, intestinal ultrasound, which you will probably see in the next year or so. But then most of the difficulties that I find that patients are not inclined to spend so much money. They do not want to spend so much money. Sorry? No, it's okay. We can see your. Can you finish your mic on a statement, please?
Yes.
I just say, as I said, that this is expense and lack of willingness to spend is the reason for a lot of small intestinal investigation doesn't get done. Enteroscopy is such
very expensive.
And majority of gastroenterologists are not very keen to do it because it's a long procedure and it's a tiresome procedure. And so there are fewer enteroscopies available. Anyway, these are but my question was you haven't mentioned about the rectal steroids as opposed
to. I mean, we do give, if we have only proctitis, then obviously we can give rectal steroids, which comes as a foam enema. So that also helps if the patient has only distal proctitis, and it can go up to your sigmoid colon as well as up to your, splenic flexure. But those are patients of Crohn's who will only have Crohn's colitis, and that too only the distal part. So there are very few of them. But yes, if your patient has a lot of disease happening in the rectum and in the sigmoid colon, we do add in for 14 days entofoam enemas. These are the steroid enemas, hydrocortisone enemas, which you get, which you can add in. It is not very convenient. Patients don't like using enemas at all, or suppositories. It's usually patients will stop using it after a few days. because it's very inconvenient for the patient. They have to use it at night. It's not comfortable. It's sometimes they can't use it properly. Then they get pain in the rectum more with the, the way in which they're doing it. So it is obviously there, but less used in, in Crohn's disease, more in ulcerative colitis.
Yes, true. I agree. Yes, I think I have finished with my comment.
There's one question. How long to use mesalamine? Mesalamine is usually used lifelong, but if the patient is on biologics or sometimes, actually in Crohn's disease, if the patient is perfectly well, we tend to stop it actually. I would not say lifelong. If the patient is perfectly well, we stop the medicine. If they have a flare-up, we use it again. But in certain patients, they tell you that if I stop the medication, then they get symptoms. So they take a minimum of 1 to 2 tablets a day. But usually mesalamine is supposed to be used lifelong in ulcerative colitis. In Crohn's, they usually tend to stop it. Another thing is if they're getting azathioprine or any biologics, then you don't need to give mesalamine. Then we actually stop mesalamine. Then they don't need to give it.
I think I just want to make final comment before I hand over the mic to Dr. Mukhopadhyay. Further, what is that? In my experience,
sorry, I just want just interrupt that. Dr. Amol Kumar Sinha has one question. He is asking a question.
Sorry. Carry on, please. Yes, Dr. Sinha, please.
Dr. Sinha, you're on mute.
Can you hear me now?
Yes, we can hear you.
Sorry, I missed your initial presentation.
Okay, sorry.
What I gather, there are some two forms of therapy in Crohn's disease. One is the non-pharmacological and another is the pharmacological. Now, I just want to ask you,
yes,
what is the difference between the two treatments with regards to particular the complications related to Crohn's disease and also the remission rate and perhaps to extend one say a cure?
So we are talking about complications are usually strictures.
No, not complications. I'm just asking if you stick to the patient with non-pharmacological therapy, that all depends on the extent of the Crohn's disease, I'm sure.
Yes, obviously in severe patients, severe Crohn's disease, you will not only try non-pharmacological therapy.
Yeah. No, so I think basic initiative. I think. Is there a role of non-pharmacological tests?
See, if you have mild to moderate disease, the studies have just come in because we had speakers from Australia as well as from Israel who have only given that to the patients to mild to moderate, and they've seen that they had two arms. One was the steroid therapy arm, and one was the your prednisolone arm, and one was the that therapy arm. So they have seen the same amount of patients have had remissions in 8 weeks. But you're talking about what is the rate of complications. I don't think there's enough information about only diet therapy and only exercise plus diet plus meditation, etc. I don't think there's any studies which are telling us what is the complication rate in that group. But these patients have to be very closely monitored. So even if you're doing diet plus other things, non-pharmacological therapy, and you feel that your patient is not becoming better, then you have to start them on treatment. I mean, you can't be sitting around waiting for that to work now. So sometimes if they don't want to take any medicines, you can start them on that and then say that if you don't become better, then we are going to add medicines. So we are not going to wait for complications to happen.
Another thing I just want to ask you, if you don't mind.
Yes.
Now, with regard to the treatment of the Crohn's disease, sulfasalazine,
yes.
Now, I have an idea that it is only limited to the disease confined to the blood gut, not to the...
No, so we are not talking about sulfasalazine. Nowadays, we are talking about mesalamine. It does not have the sulfa group.
Yes.
So mesalamine has different formulations. So in India also, we get, the Sun Pharma also makes two formulations. One is released all over the small gut, which is the it's a CR variety, or all over the world you get Pentasa, which is released in the small intestine. And one formulation you get is only released in the large intestine, which we give in Crohn's colitis as well as we give in ulcerative colitis. So you get two different formulations of the same drug, mesalamine.
I think we had spent a long time on this topic. Can we hand over the mic to Dr. Manoj Mukhopadhyay, please, to carry on the next proceeding?
Okay, thank you very much, Dr. Subhashachi Ray, for conducting this question answer session, and Dr. Deepika Kedia. We are extremely loose presentation, and taking time off. I will thank you once again at the end, because you've taken time off to speak on two topics, because one of our speakers couldn't join because of personal commitments. Okay, so let's move on to the next topic. It's a topic on insulin. The topic is insulin co-formulations, unraveling the strong wall of evidence. And it'll be a conversation, as Dr. Shekhar Chak would like to put it. So Dr. Shekhar Chakrabarty is one of our fellows for quite some time now, and he's a well-known specialist in diabetes, not only in his hometown of Siliguri, but in West Bengal and throughout India, and he's involved in several academic circles of the API. So with this, Dr. Shekhar Chakri would like you to start this discussion or conversation on co-formulations of insulin. Thank you.
Good afternoon, Dr. Mukhopadhyay and all who are present in the session. Am I audible to you?
Yes, you are.
Yes, yes.
Yes. Okay. After having a nice talk delivered by Dr. Kedia, so I'm delivering a talk which is basically a straightforward talk on a particular molecule which is being used as a therapy for diabetes. And you all know that this is for a pretty long time, since 2013 it is available in the market. And today's program is sponsored by the Novo. This is the formulation which has been invented by the Novo and being marketed. Now, with this, at the very outset, I must make a comment on that how a premix differ from a co-formulation. You know that the premix insulins basically are the same insulin which has got a short-acting component, and it has been made an intermediate acting by adding the protamine and the zinc to it. But the co-formulation is a different type from the premix insulin, where the two different types of insulins are mixed together in a single syringe, where the patient, it appears to be very convenient for the patients. So I'll talk about the co-formulation, which is a little bit different from the premix insulin. And I would like to show in a couple of minutes how it differs from the premix insulin and what its relevance to use, particularly in the Indian subjects who are suffering from diabetes. Now we look into the journey of the premix insulin. You'll see that 1921 the insulin was discovered, and in 1973 the monocomponent animal insulin preparations in ultra pure form has been started using, and in 1980s the recombinant human insulin, which is basically a biphasic insulin, where it is a rapid acting insulin of 30% and NPH of 70%, has been used. When the analog insulin was discovered, you'll see since 2000, the Lispromix insulin has been started. Then in 2001, the biphasic insulin Aspart came into the market. Following which, around 2013, a co-formulation preparations of insulin deglutide, which is basically a basal insulin, and aspart, which is an analog of insulin, are co-formulated together and being used. Now, till 1980, when we used to use a biphasic human insulin, our prime target was to control the fasting and as well as the postprandial sugar. It was simple and convenient. We used to use it with a OD or twice daily. But the problem with that insulin was that there was no mealtime flexibility, and the PPG control was not that good, and there was associated hypoglycemic risk. When we came to in the era of the premix analogs, the certain achievements have been shown. One is the mealtime flexibility has been achieved. More effective with the biphasic insulin, the postprandial sugar was well controlled, and the risk of hypoglycemia was reduced. Now, but the opportunity of the fasting control was still there, and the low risk of high risk of hypoglycemia is still there. These are the some areas which were problematic and were very difficult for the clinicians and the diabetologists to address. Then the co-formulation has been invented, where there is a better fasting and PPG control, allows the very low risk of hypoglycemia, and also the lesser dose of insulin is required. Now, this is basically how the formulations has been designed. You will see on the left-hand side, the insulin dihexamers, which is basically deglutide insulin, which is an ultra-long-acting insulin. This is basically a dihexamers. And on the right-hand side, you will see that the short-acting aspart insulin, which is basically hexamer, are co-formulated together in a single syringe, where it is the IDES asp. And these two insulin components don't interact with each other in the solution, as well as in the subcutaneous tissue when it is injected in a particular patient. So both the insulins retaining their own identities, as well as the mode of actions, as well as the effectiveness in the patient. So this is IDEG as with the world's only co-formulation insulin we use. Basically, this is one of the great inventions which we see. So this is the combinations of the quick release. You see how when we inject the patient with the IDEG as co-formulation, it has got two components are injected together, which is deposited in the subcutaneous space. And once it is deposited in the subcutaneous space, you will see that the phenol is a component of this molecule, is diffusing quickly, and the IDEG dihexamers, they link with each other via a single side chain, and they form a multi-hexamers. These multi-hexamers remain as a subcutaneous depot of the insulin when subsequently there is liberation also, when the zinc diffuses out slowly from that, and gradually the hexamers disassemble and releasing the monomers slowly. Simultaneously, there is IASP insulin, that monomers are released very rapidly in the circulations. So we get at a time that rapid acting insulin, which controls the prandial aspect, which is fast acting, and we also get a flat and steady state release insulin, which controls the interface, between the meals. So we see that particularly with the once daily use of IDEG insulin, both the prandial as well as the in between meals, there is post-absorptive states are well controlled, with these both the components. Now, what happens? Is it relevant for the Indian subjects? In fact, the Indians and South Indian, the people of the Southeast Asian, they have got the particular predilection, or they take more amount of the high carb diet. They have got the more postprandial sugar levels, as well as they have got the patients uncontrolled on the multiple OADs. And so they need a safe and convenient therapy. So this is the Indian realities for the diabetic management we encounter. Now, whether it is fit to this, I would like to highlight on it. If we given a subcutaneous insulin of the IDEG RASP, then we'll see that this controls the postprandial sugar as well as the fasting sugar, and also those patients who are not uncontrolled with the multiple OADs, that is addressed with this particular insulin. So we have got enough evidence in our hand in the form of different RCTs, and as well as the real world evidence we have with this insulin. You see, the IDEG as it has been extensively studied in the different third phase and phase 3A and phase 3B, with the comparison with the different types of insulin, like insulin betamide, is an biased 30 insulin, insulin glargine U100, insulin glargine U300, as well as the basal insulin plus IASP with meals, basal bolus therapy, as well as that IDEG ASP. So these are the different comparisons has been made, and the trials have shown very encouraging figures. You'll see when the efficacy and the safety of the IDEG ASP has been compared with the once daily basal insulin, like say insulin glargine U100, you'll see that the patients has been put in one arm with the IDEG ASP, and the other arm is the glargine insulin U100. You'll see that in the arm where there is IDEG ASP, those group of patients are having superior control of the HbA1 reductions, and the fasting glucose is well controlled, as well as they are almost 57 milligram more control of the postprandial sugar. It has been observed that it has provided a superior long-term glycemic control when compared to the glargine U100 with the lower risk of hypoglycemia. When we have compared that the IDEG ASP with the basal plus insulin therapy means, then the basal therapy with multiple doses of short-acting insulin like insulin aspart, along with the oral hypoglycemic agents, you'll see that there is significantly lesser dose requirement, around 12% in case of IDEG ASP therapy. There is also 45% significant lower risk of the nocturnal hypoglycemia, which has been observed in this study. There is also, when we compare the IDEG ASP with the basal bolus therapy, that the two important issues have been addressed. One, that there is lower dose of insulin is required, as well as there is fewer injections is required, because you know that the basal bolus therapy, there is at least 3 to 4 injections per day is required, but IDEG ASP either a once or a twice daily, max to max twice daily insulin therapy is required. So there is better achievement of the improvement of the fasting, as well as the glucose, as well as the HbA1c level compared to the basal bolus therapy. There is around 6.6% significantly lower dose of IDEG ASP versus insulin glargine U100 plus aspart, and fewer number of the injections, which has already been mentioned. Now, when we also compare the basal insulin with the IDEG ASP, the two important issues are also came into the picture. One is that the changes in the mean self-measured glucose and as well as the mean and the postprandial glucose. IDES has significantly reduced the mean self-measured glucose level as well as the postprandial glucose level compared to the basal insulin. So with this RCT, I'm moving to the real world evidence where there is a lot of studies and good number of the studies from the India has also been published for the couple of years, and we'll find the robust data of IDEG as in the real world evidence. One paper has been published in 2019 in IDF, where it has been shown that there is insulin when compared with the insulin glargine 300, and there is you'll find that IDES has caused the statistically significant greater reductions of the HbA1c as compared to the insulin glargine 100 and U300 arm. There is also significant beta reduction of the fasting glucose in both IDEG and U30 compared to the U300. Significant better postprandial glucose control in IDEG as compared to the I-glargine U100 and U300. Also, there is significant increase in dose requirement in glargine 100, where in case of IDES, as there is dose has been reduced when we compare from the basal in a follow-up therapy. There is non-significant increase in the IGLAR U300 and the IDES arm. So there is also significant reductions of hypoglycemia in case of glargine. I mean both U300 as well as in the IDES. So therefore, not very much significant difference between these two. So another important issue which has been addressed, that is the time to treatment intensification. So when it is basically the time between the index date, when the HbA1c started increasing from the 4% to the first prescription for the additional anti-hyperglycemic agents started, or the dose has been intensified during follow-up period, it has been compared between the different molecules, and it has been shown that in IDEG, as the average time to treatment intensification is around 11 months, but which is in case of IGLAR group is 6.7. That means that after 11 months, you have to intensify. As well as the number of the patients intensified is only 11%, when around 17% patients of IGLAR group has been intensified. So therefore, significant fewer subjects on IDEG as required dose intensification. And additionally, the time to treatment intensification was significantly longer in the subjects who received IDEG as compared to the IGLAR U100. So another important issue, when we try to switch over from the IDEG as to either U100 or U300, it has been shown that the significant reductions of the basal as well as the total daily insulin doses at the end of the 26 weeks, as well as there is significant improvement of the quality of life is related when we switch over from U100 or U300 to IDEG insulin. So there is around 74% people preferred the IDEG as compared to the U100 and U300. And switching to IDEG as is associated with a lower total basal insulin requirement and significant improvement in the quality of life. In fact, the quality of the life has been improved tremendously. We see that 94% of the people, they manage their day-to-day life better when we initiate or switch over from the Uglar 100 or 300 to the IDEC. Around 88%, 89% have the improved quality of the life because they have got a lesser number of the pricks. And also they found it is more comfortable injections in the different social situations. Because this insulin has got a tremendous flexibility. This insulin can be taken prior to meal, during meal, or after meal. Say, for example, if you is going to any social sort of occasion, then this flexibility is very much required. So reductions in the number of the insulin pricks, flexibility, and simplicity of the dosing of IDEX has translated a real better quality of the life. So therefore, also there is the reductions of the pill burdens. It has been observed that those patients who are taking 3 or 4 pills, oral hypoglycemic agents, are reduced to 2 pills or 1 pill when we start this IDES as along with the oral therapy. So reduced pill burden also improve the quality of life, and adherence to treatment with the insulin with the diabetic patients has been ensured. So therefore, around 70% patients from 3 oral pills come to 1 oral pill, and 50% patients are coming from the 2 oral pills to 1 oral pill. So therefore, the oral pill burden has been reduced. It is also important to understand that the cost effectiveness is also improved with the initiation of the IDEX. If you really calculate the total cost, including the medication and the healthcare resources, you'll see that the all treatments joining together, calculated together, has got a better cost, or it is more costly compared to the IDES as when you take compared to the other. So therefore, there is yearly cost benefit has been observed around 3,000 benefits the patients actually incur. So the IDES therapy is also cost effective because why the cost is important? Because the therapy is lifelong and it is a lifestyle disease. So the patient has to continue the therapy for a pretty long time or lifelong. So therefore, cost is an important issue to be considered. And IDES therapy shows that the better cost effectiveness in case of IDES. So guidelines also suggest that RSSDI ESI clinical practice guidelines 2020 suggested that the IDES is the recommended as a choice for the insulin injections. We, the clinicians, should consider that the patient should not consider insulin as a threat, and we have to alleviate the anxiety of the patients so far the insulin is concerned. And the insulin therapy should be considered in all patients who are failing to achieve the glycemic targets after taking 3 oral agents. The advantage of this particular therapy is that as it is a co-formulation, so you need not to change the insulin syringe. When you combine a basal bolus therapy, you have to have a 2 insulin syringe. One is basal and one for bolus. But here you will find you will get a same benefit of the basal bolus therapy. So you can easily initiate, you can easily optimize, and you can easily intensify of the therapy with a single device. So you can start with an once daily, and then you can change to the twice daily, but you need not to change the insulin or syringe. So this is the greatest advantage of these patients. So therefore, RSSDI 2022 clinical practice recommendations also suggest that IDEG ASP is the recommended therapy because it causes the least hypoglycemia or requires fewer doses and causes less weight gain, has the flexibility of the administration before any large meal of the day, and can be given on the different meals of the different. For example, if you take sufficient amount of food or you have got a greatest meal during lunch, you can take today before the lunch. If you have got a greatest meal in the dinner the following day, you can change over to the dinner on the next day. So this flexibility remains. So there is least chance of hypoglycemia, more flexibility, and as well as the least waist gain. So practical considerations is that we should initiate the insulin with the 10 units insulin IDES as once daily and should be administered before any major meal. Ask the patient, what is your major meal? If he says, yes, I take major meal in the breakfast, then you start before breakfast. If the patient says, okay, my major meal is lunch, you start before lunch. If the patient says that my major meal is dinner, you start before dinner. Once daily to start with, then you gradually up titrate, and it can be different, even the different times of the days. You start from the oral, then you gradually up titrate to make it is twice daily. In fact, you can up titrate is if the fasting sugar should be your target first. If not achieved, then you can up titrate 2 units plus. If the fasting glucose is maintained, you can keep it here. If the fasting below the target, you reduce the 2 units of the insulin. You can change what I have said, that the changing could be before breakfast, pre-lunch, or pre-dinner according to his meal. And accordingly, we should check the capillary blood glucose in fasting state, pre-dinner, or pre-breakfast. So these are the advantages. And this is the most advantageous insulin. In fact, I have faced in my clinical practice because of its flexibility, its good safety, low hypoglycemia, least weight gain, and a better control of the blood sugar. Thank you very much. And this is what is a basal premix. You can start with a basal premix to IDES, basal premix twice daily. When, say for example, how to switch. If the patient is on a basal or a premix once daily, you first convert to a once IDES. If the patient is taking twice daily of the basal or premix, you just switch over to IDES as twice daily or once daily. If the patient is on basal bolus, the IDES as is individualized as required. So to start with a once, then you change to the twice daily and up titrate or down titrate according to the results which you find in the fasting, pre-lunch, or pre-dinner values. So switching needs to be individualized based on careful consideration of the basal bolus doses, and close blood sugar monitoring is certainly required. It is effective in across the all comorbidities. It is effective across the all ages, and it is very good for the elderly persons as well. So thank you very much for your patient hearing.
Thank you, Dr. Shekhar Chakraborty, for giving a very simple way presenting a new insulin which is available. I don't know when you were a medical student, but I'm sure some of my seniors in the audience would remember that we had a soluble human insulin and we had NPH insulin. And the NPH insulin had to be actually pre-mixed, mixed actually. So physically mixed like a pill rolling movement between the palms of your hand, really, before you took that. And you should tell the patients that, you know, take a জলের মতন ইনসুলিনটা 5 ইউনিট নেবেন আর ঘোলাটাইন ইনসুলিনটা 10 ইউনিট নেবেন, and actually they used to physically mix it in the same syringe. But we have come a long way from those, actually, though of course in the some of the government hospitals and some of the patients can't afford the insulins, still have those. But we've come to these insulins which are the basic difference, as Dr. Chakraborty mentioned, is that the two components are much superior to the two components which were present in the human soluble insulin, the NPH. That the fast-acting component, as you mentioned, the aspart, works so fast that you can take it even 15 minutes before or even 15 minutes after your meal. So it start working so fast, and it peaks exactly at 2 hours, which matches with your postprandial peak of your meal. The basal component is really unique. It is It is the flattest basal insulin which is available worldwide, for our patients with type 2 diabetes. Okay, as you saw in one of his slides, it starts working, and you can see there was hardly any peak. The NPH insulin had a peak, and therefore prone to hypoglycemia. Therefore, the incidence of hypoglycemia with the insulin degludec, which is the basal component of Ryzodec, is minimal. So I think we've used it, and also you mentioned that a basal bolus insulin, 3 or 4 times a day with a twice a day Ryzodec, you got a very similar type of control with a lesser number of pricks, lower insulin requirement, and the most important thing is the lower incidence of hypoglycemia when you're using this, so that the patients can achieve their targets in a much safer manner than they were able to do it maybe a decade or two ago. Okay. So any questions from the audience before I ask a question to Doctor? I can't see anything in the chat box. And
I want to ask a question.
Okay, Dr. Kedia.
Excellent talk, Dr. Chakravarti. I just want to know that when you are stepping up from oral hypoglycemic to this particular, formulation of insulin, how many patients then manage to go on a strict diet and exercise and lose weight, and can you step down and stop this insulin formulation? How many patients or what percentage of patients can you do this?
Dr. Kedia, it is very important to note that the diabetes is a lifestyle disease. So therefore, if you properly do a diet control and exercise, there are studies that you can revert back to diabetes to a normal situation.
Yes.
I mean, normal glycemic state.
Yes.
And also there are certain therapies. Even you see that the bariatric operations also revert back to the diabetes. So it doesn't mean that the diabetes is once and diabetes for all the time. If the patient can properly do the exercise, and we have seen number of the IGT and IGF patients with the proper exercise and diet control, they can they become the euglycemic, and it is being maintained for a pretty long time. The point is that the patient is having a very high HbA1c level, and the patient has on the 2 to 3 oral drugs, then it is very difficult. The studies, different studies of the exercise protocol and the diet protocol combined together, it has been shown that the HbA1c reductions is combining together is roughly around metformin, around 1 to 1.2% maximum. So therefore, if the patient has got an HbA1c is around 8, and if my target is 7, then we can achieve that target by the HbA1c, I mean, with the diet control and exercise. But if the patient has got a very high HbA1c level, say for example, more than 9 or 9.5 or 10 like this, so only instituting or only starting with the diet and exercise, it is not possible to come to the target. Then you have to put the patient on pharmacotherapy, and that will reduce the HbA1c along with the lifestyle modification with the exercise and diet. Then with this, it is possible to maintain the HbA1c, or once it is achieved, has to be maintained. Once it is maintained over a period of time, say over years and years, then you gradually reduce the oral hypoglycemic agents or insulin, whatever pharmacotherapy the patient is getting. And if you find that even the omission of the pharmacotherapy is maintained, the HbA1c on 7, only on the lifestyle medication, it is fine. The patient can maintain with on these medications. But really, the patient has to adhere to the lifestyle modification, which the patient must be properly motivated, and the doctor, nutritionist, podiatric, exercise, those who are, therapists, those who have to, involve the proper time and sincerity to make this achievement. So it is very difficult for the patient, and even the reductions of the body weight also important. It has been shown if you can reduce the body weight more than 15%, then it is possible to achieve to reverse the diabetes. So therefore, it is also very difficult once you achieve the target. to maintain the target over the period of time. The studies have shown that once by exercise and diet control, once the body weight target is achieved, then after a year, around 40 to 45% patient, they start gaining body weight. And again, the status of the hyperglycemia or the glycemic status is getting worse. So therefore, achieving the target and maintaining the target and the body weight as well as the glycemic status are very important. Sometimes it appears to be very difficult for the patients, but if the patient is motivated enough and if the patient can maintain this, it is possible.
Thank you.
Deepika, the answer to your question basically is that if you want to reverse the diabetes, it has to be very early in the diabetes stage, within the first 5 years. If you are waiting for after 10 years or 15 years, it is very difficult to reverse. It all depends on your beta cell mass. If your beta cell mass is very low, you're unlikely to reverse it. And so even if we have, as Dr. Chakraborty was saying about bariatric surgery, the reversibility is possible. It is possible also with 15% body weight loss. But maintaining that weight loss and in the future, that will depend on how what is the duration of your diabetes. Okay.
Thank you.
And it's come. Okay. Thank you. Dr. Gopal Chattopadhyay wanted to ask something.
Thank you so much, sir. Thank you. First of all, thank you so much, sir, for a wonderful presentation. A lot of data, a lot of information, and a lot of new stuff for me, at least.
I'm not visible. Gopal, you're not visible.
Oh, right. Okay, that's fine. Am I visible now?
Yeah.
Right. Thank you. Thank you so much, sir. There are just two things. I think the second part of my question has been partially answered already in the last explanation that both of you gave. So my first question would be, are we aware of any particular side effect profile of this combination? And my second question, probably in the same line or an extension of the first one, would be in a patient with established long-standing diabetes, and especially in the subpopulation which has extremely labile blood sugar levels, how effective is this new combination? And again, is there any particular side effect profile that we should be worried about?
Okay, Dr. Gopal, the thing is that the first question is that the side effect profile is there are the main two side effect profiles of the insulin therapy. One is hypoglycemia and another is weight gain. So these two profiles are least in this co-formulation compared to the other short-acting insulin, intermediate-acting insulin, and the basal insulin. If you compare, and the studies have shown that this co-formulation has got a least hypoglycemia as well as the least weight gain. So therefore, the side effect profile, yes, as we use and the insulin, which is basically a hormone which is remaining in our body. Though we will try to get as physiological pattern as possible, but it is not possible till today. What the physiology in our body maintained in vitro insulin, in vivo insulin secretions. So therefore, there is some difference of these pharmacological therapy vis-a-vis the insulin secretions in vivo in our body. So therefore, as there is some difference, so there certainly some amount of hypoglycemia will remain, and some amount of the body weight will increase. But the amount of the hypoglycemia and the amount of the body weight gain are
is much lesser
among them. And also, what you have mentioned that the labile hyperglycemia is an entity. In fact, these patients are having some sort of, usually are having other endocrinal problems along with this. So if there is and such problems is there, then we have to address other endocrinal problems. Say, for example, if the patient has got hypercortisolism or low cortisol, if the patient has got a high hyperthyroidism or low hypothyroidism, these sort of patients might have, or the patients has got a pheochromocytomas. So these patients might have this problem. This type of insulin co-formulations is the best insulin to use in case of labile hypoglycemia, because these patients have got a least chance of hypoglycemia. In that case, it is better to start a lesser dose of 10 units. If you, the usual recommendation is you start with the 10 to 12 units to start with, is roughly around 0.2 units per kg body weight. If you consider a person of 50 kg and a 0.2 units per kg, units per kg body weight, it comes to 10 units. In that case, if you are not very sure, you start with a 0.1 unit per kg body weight. So you start around 5 to 6 units to start with, which we usually do sometimes in case of patients having the chronic kidney disease. We start a very lesser dose, a short-acting insulin, and once the patient is put on a number of pricks on the short-acting insulin, when we switch over to a premix insulin or a co-formulation, we start with a very minimum dose, like 4 units or 6 units to start with, and see how much effectiveness or hypoglycemic episodes the patient is having. So in case of labile hyperglycemia or hypoglycemia, you should treat the patient very cautiously and start with a lesser units of insulin to start with, and then up titrate according to the requirement of the patient.
Fantastic. Thank you so much. Thank you.
Okay. So are there any more questions? Please unmute and ask your questions. Yeah,
I have,
Dr. Ray.
Yes, I have I've been a learner more than anything else, but I've been bystander in my patients having treatment of diabetes. And I notice that as always, there are a number of drugs, rather too many drugs in my eyes, and yet they're not controlled. But there is another problem that you face as a diabetologist, that is phobia of insulin, because they're not phobia to injection for it. So it's difficult, isn't it a difficult job to perform as a diabetologist to persuade these patients to cut? But later on, they're thankful. Initially, it may be very difficult.
Yes, there is a lot of barriers to initiate the insulin therapy, and the barriers from the aspect of the physicians as well as the patients. So, but the very important is that you have to break the barriers, and we have to initiate the insulin therapy as early as possible when it is required. So therefore, it is though difficult, but not impossible. And there is an art of initiating the insulin therapy on the behalf of the doctors as well as the patients. So the clinicians of the diabetologist and the patient should be educated. Patient should be educated how to initiate, and that phobia should be ameliorated. That is most important.
There's also another point I noticed, that still that a lot of people depend on their spouse or children to give their insulin, which is probably very impractical, but it's still there. Isn't it true?
Yes, that is also in a problem. But the thing is that when we have started our practice, say 20 years back or more, then it was very difficult to educate the patient for the self-injections. I think now more and more number of patients are recruited and they are encouraged for the self-injections, because the self-injections are very easy, is very convenient, because the very thin needle, around say 32 gauge needle, and it is just like here the thickness, and it is almost painless. And how to dial the syringe and how to inject, once the patients are educated and they learn how to do it, then it is very easy for them. So it is also the part of the doctor, or as well as the insulin therapist, or as well as the insulin educator, to educate the patients. Because in my diabetic clinic, I have got an insulin educator, and all the patients, before starting the insulin, there is my educator educate the patients in a counseling room how to initiate the insulin, what are the problems of the insulin, to how to preserve the insulin, how frequently the needle should be changed, how to dial it, what are the problems, when you call the doctor, what are the awareness of the hypoglycemia, what is hypoglycemia unawareness. All these are being taught within half an hour. And the insulin educator then give the first injections of the insulin to the patients if the time permits. Otherwise, they educate the patients how to, and self-injections started. So this amount of motivation, this amount of engagement, this amount of sincerity is required to educate all these patients. So once the patients learn, then self-injections is not a problem. We are approaching from a joint family situation in India to a nuclear family situation. Lot of elderly patients are staying at home alone who are diabetic. It is very difficult to get their spouse or the children for the insulin injections. And social support in our country is not that very robust or very supportive. So that's why the self-injections is the need of our in our country. So every patient to initiate the insulin injections, the how to initiate and how to maintain the therapy should be educated.
A lot of the pharma companies have education services. Shikor,
Yes.
you have, I have, the specialists have education in their clinic, but the pharma companies are also going to do it for you, not only in your clinic, but also at the patient's house. Okay.
Yes.
And I think that follow up, and they are educated a little bit. They have certain apps where they can put in their sugar reports. They can be told how much insulin to take, because it's not always possible for them to get in touch with the diabetologist every time when they want to change the dose. So there are a lot of support services that have come up. So things are much better, and majority of our patients are actually taking their own insulin. Okay, so thank you very much for your patient hearing, and thank you, Dr. Shikar Chakraborty, for taking this session on insulin co-formulation and how it's changed the way we treat our diabetic patients. And thank you, Novo Nordisk, for sponsoring this talk. So with this, I hand over the session to Dr. Amol Kumar Sinha and Dr. Deepika Kedia for the final talk. Dr. Amol Kumar Sinha, please.
Right. Can you hear me?
Sure. We can't see you. If you move your camera a little bit so we can see you better. That's all. We can see you.
Can you hear me? Can you hear me?
We can hear you. Definitely we can hear you.
Okay. Let's start here. So just we heard about the metabolic disease related to diabetes. So we're moving to another metabolic disease, which is non-alcoholic fatty liver disease. And it is quite common, and it's a form of chronic liver disease. And for the last few years, there has been increasing importance, particularly recognition of the disease, because of the fact that it is linked to insulin resistance, and it is associated with obesity, and it is also associated with metabolic disease, hypertension, dyslipidemia, type 2 diabetes, and hyperuricemia, and to the extent one can say hypothyroidism. Apart from that, there is one important area is the NASH going to fibrosis and most important hepatocellular carcinoma. So there has been a lot of work has been done in this field, and one has to determine earlier the disease and better treatment. And to discuss this thing, we got a very good speaker, Dr. Sunil Acharya.
Sorry, you are not watching. Sorry, you have not watched it. They already mentioned by Dr. Mukhopadhyay that due to some uncertainty of the availability of Dr. Acharya, Dr. Deepika Kedia agreed to take over with a short notice.
Oh, is that right? I didn't know that. But anyway, sorry.
Dr. Deepika Kedia again.
Deepika, I'm very sorry. I didn't mean that way. But we got a very good speaker then. Just introduce Dr. Deepika Kedia. So she's going to talk on the non-alcoholic liver disease. And she's going to give an idea with regards to the various aspects of the disease. And please, Dr. Kedia, please.
Thank you, Dr. Sinha. Just starting my talk on non-alcoholic fatty liver disease, and I think all my friends out here who are endocrinologists, they have the maximum patience with them, and my request to them is that if they can at least do a liver function test and ultrasounds on their patients, because diabetes is now, the complications of diabetes is being very well controlled by our friends, but the problem is what is killing these patients are cardiovascular disease and liver disease, cirrhosis. So with this statement, I start my talk, non-alcoholic fatty liver disease. This is the outline of my talk today. What is the definition of NAFLD? In short, non-alcoholic fatty liver disease is called NAFLD. Fat, largely triglyceride exceeding 5 to 10% of the liver weight. And this is because of failure of normal liver fat metabolism. There's a defect in liver cell and excess delivery of fat, fatty acids, and carbohydrate. There's evidence of hepatic steatosis either by imaging or by histology, and no causes of secondary hepatic fat accumulation should be there. That means no significant alcohol, any medication, hereditary disorders. And now NAFLD is considered as a hepatic component of metabolic syndrome because of the close association between the two conditions. And in fact, all over the world nowadays, they have started using MAFLD. That means metabolic associated fatty liver disease all over the world. This term is being used instead of NAFLD. But for today's talk, we are talking about non-alcoholic fatty liver disease. We have to make sure that our patients are not drinking a lot of alcohol, because you will see when you take a detailed history that along with NAFLD, patients are drinking a lot of alcohol. So less than 20 grams, both for males and females. And we have to understand that 30 ml of whiskey is equal to 120 ml of wine, 240 ml of beer is equal to 1 unit of alcohol, which is 10 grams. So they cannot drink more than 2 drinks in a day, and they have to have two dry days in the week for the liver to recover. There are lots of common causes of secondary hepatic steatosis, commonly being alcohol consumption, macrovascular, hepatitis C and Wilson's, and micro, you have medications, valproate, acute fatty liver, pregnancy, HELP syndrome. These are the common ones we get to see, because a lot of pregnant women nowadays are getting fatty liver. So we get to see this commonly. And so NAFLD is histologically divided into non-alcoholic fatty liver and non-alcoholic steatohepatitis. So the definition of non-alcoholic fatty liver is the presence of hepatic steatosis with no evidence of hepatocellular injury in the form of ballooning of hepatocytes. And NASH is defined as the presence of hepatic steatosis and inflammation with hepatocyte injury, which is the ballooning, with or without fibrosis. So NASH will cause progressive fibrosis, which will cause cirrhosis, and then you have liver failure and death. And up to 25% of our NASH patients will develop cirrhosis over a period of around 8 years. So it is very important that we identify those patients early. So you have the normal liver, and then you have the non-alcoholic fatty liver disease, which is the NAFL. And then when they start getting a lot of inflammatory cells coming into the macrosteatosis or microsteatosis, then you develop NASH. So when we come to NASH, there are associations here. The conditions with established associations are obviously obesity, type 2 diabetes mellitus, dyslipidemia, and the entire metabolic syndrome. That is central obesity, hypertension. And other associations are polycystic ovarian disease, hypothyroidism, obstructive sleep apnea, hypogonadism, hypopituitarism. So these are the other associations, and we see a lot of obese patients have obstructive sleep apnea. So there is overlap between the two, and polycystic ovarian disease usually also happens in patients who are overweight. So there are, linked to each other, and a lot of studies which have been done on the general population in India, at least 4 studies, they're all showing that the incidence of NAFLD in our country is anywhere between 10 to 30% in our population. And these have usually been picked up by liver ultrasound. Usually liver ultrasounds have picked up the fatty liver patients. So diabetes in India, I mean, we have a lot of endocrine people in the in this group, and you know that it is rising in our country. And in 2011, there were like 62.4 million people, and I'm told that there are at least 70 to 80 million people in the country, which is nearly 8 to 10 crores now. And metabolic syndrome requires the presence of 3 or more of out of the 5 to call it metabolic syndrome. That means you have waist circumference above 102 centimeters in men or 88 centimeters in women, which is central obesity, triglyceride above 150, HDL less than 40, and then systolic BP above 130 or diastolic BP above 85, fasting plasma glucose above 110. But for Indians, it is much lower. Your normal BMI we consider is, between 18 to 22.9. So even if the patients are, they have a BMI between 23 to 25, we consider them overweight, and obesity is above 25 kilo per meter square. And waist circumference, again, for Indians is much less, above 90 centimeters for men and above 80 centimeters for women. So incidence of NASH worldwide is 6 to 33%. And the general population it is up to 5%, and usually it is found in ultrasound. So if you do different studies, if you look at different studies, it ranges between 17 to 46%. And in US, you have 10% patients who have NASH, 3% will have advanced fibrosis or cirrhosis. So that 3% is 6 million patients, and in India, obviously, it is much higher, because we have a lot of more obese population and more diabetes in a country with the diabetes capital of the world. NASH is the most common cause of liver disease in US and India. And unfortunately, NASH has now, become number one, removing hepatitis B and hepatitis C to second and third position. NAFLD has been observed to be consistently associated with type 2 diabetes mellitus, up to half percent, and half of your patients will have it, and dyslipidemia up to 92% patients. And also high triglyceride level, low LDL level are present in 62% and 54% of NAFLD patients respectively. So we have to make sure that all our diabetic patients or all our dyslipidemic patients, we do check up for NAFLD, and vice versa, that if a person comes in with fatty liver, we check them out for these things also. So in our country, we have more than 25 million patients, so that is 2.5 crores, but they're saying this number could be up to 5 crores of NAFLD patients who are at risk for significant liver disease. And the prevalence is, at least 50% in the diabetics, like I told you. And the increased prevalence of insulin resistance in these patients with NAFLD is up to 100%, between 83 to 100%. So it is increasing with age. In older patients have more advanced fibrosis, more men than women, and Indians are more likely to get NASH. Obesity, if your patient is more than 10 to 30% over ideal weight, then they have a very high chance of getting 70% of those patients will have NASH. And if you combine NAFLD with type 2 diabetes, then the chances of your patients having advanced fibrosis is 57%. So it is very high. NASH is going to be 84% in these patients. So more than half of your patients are going to have advanced fibrosis. And these advanced fibrosis patients can move on to cirrhosis. So you can imagine the burden of cirrhosis in our country is going to increase over the number of years. So more and more cirrhosis, more deaths from cirrhosis, and more liver transplants happening in a country. And to think that each liver transplant is so expensive, most patients cannot afford it. So usually NASH is symptomless. Fatigue, malaise can be there, and right upper quadrant, discomfort can be there. But you have to do a detailed examination, check for the liver span and all signs of chronic liver disease. We have to check the height, weight, BMI, waist circumference, waist to hip ratio for the assessment of overweight patients and central obesity, as well as overall obesity. We do complete hemograms, liver function test, PTM, INR, because you might have a patient who has not had an ultrasound done, but has got a high INR, and those patients are your early cirrhotic patients. Other components of metabolic syndrome like hypertension, your impaired glucose tolerance, triglyceride level, HDL level, hemoglobin A1C, and we have to calculate the insulin resistance. Screening for hepatitis B and C, because if your patients are negative for these, hoping so, then you have to obviously make sure that you vaccinate your patient. And all the autoimmune markers should be done. Celiac workup has to be done, and serum iron profile and cellular plasmid if your liver function test is abnormal. This is how you calculate your insulin resistance. I say I'm sure most of us know how to do so. And now I just want to show you these two liver function tests out here. On the left side, you have only a gamma GT which is high. So a mild gamma GT high with the AST, ALT high is what your normal fatty liver patients are. But if they have NASH, then you'll have a AST and ALT levels which are also high, as well as your gamma GT is going to be high. Usually ALT tends to be higher than AST, but it can be vice versa also. If your patient is drinking significant amounts of alcohol, then AST tends to be higher than ALT. So continuing with this, you have to do your alpha fetoprotein in cirrhotics. Ultrasound abdomen is a must, and you must write for the liver span in the ultrasound for the doctor to do it. Echo texture, any portal hypertension and ascites. CT scan abdomen, if we have to do triple phase only, and no other CT scan is allowed. You have to do a triple phase of liver. And we are also checking out for HCC, because in our NASH patients, the incidence of HCC is becoming very high. We are doing fibroscans on a patient. Then we are doing the NAFLD fibrosis score, which can be calculated online with age, BMI, platelet, albumin, AST, ALT. For diabetes or impaired glucose tolerance, you have to answer yes or no, and you get a score. MR elastography is also very easily available in our city. It's slightly expensive. Liver biopsy is not done anymore, only in clinical trials or in academic centers, and we have to regular follow up of patients. So liver biopsy, just want to show you that a normal liver has a portal vein, you have a bile duct, you have a hepatic artery, this is a limiting plane, and this is a normal histology. So what happens in fibrosis? In F1, you will have portal tract fibrosis, your central vein is normal. In F2, the septas will start coming out from the, from the portal tract and will start going towards central vein. When these start more or less connecting the central vein with the portal tract, these are called F3. And when you actually, form lobules like this, then this is called cirrhosis, and this is F4. So in liver biopsy, the problem is there's too much sampling variability and, associated sampling variability and also invasiveness. None of the patients want to get it done, and even the doctors are not keen to do liver biopsies because of the side effects. Second thing is, they have done studies on this, and they've seen that 1/3 patients out of 124 patients had a stage 1 difference in fibrosis when they took it from the 2 different lobes laparoscopically. So you can imagine if from the 2 different lobes you're getting different results, what will happen if you're taking it from the same, lobe in different areas. And you can also cast the NASH activity score, which is a NAFLD activity score, NAS, that composes of steatosis, inflammation, and balloon scoring. And in clinical trials, they use NAS a lot, but obviously we don't use this because we don't do liver biopsies on our NAFLD patients. And it is a 8-point scale: steatosis 0 to 3, lobular inflammation 0 to 3, and ballooning 0 to 2. I just want to show you this, that if you're taking, if you're looking at this biopsy, the sampling error, you think the fibrosis score is 65% because of the amount of fibrosis you're seeing. All these blue areas is your fibrosis. So you think this fibrosis score is 65%. But if the cut is taken from this area, this is only 15%. So you can see on the same biopsy specimen, depends upon where the cut is done, you can have different results. So that is why, we have stopped doing liver biopsies because of this reason. You have a lot of fibrosis markers available, but the common one we do is APRI, and you can do a NAFLD fibrosis score online. We don't use the others, they're expensive ones. And cytokeratin 18 fragments again is not available, in the available to us clinically. Only some academic centers are doing this. So fibroscan, basically we are checking the shear wave velocity, transient elastography of the liver. So the the reason behind this is when you're passing sound waves through the liver, if your liver is soft, then you get the velocity of sound is lower, so you get a lower reading. If the liver is stiff, and because there's more fibrosis and more scarring, then the the sound passes much faster, and your this thing reading is high, and that is the reason why in fibroscan, when you get a bigger higher reading, the patient tends to have cirrhosis, and a normal person will have 6 kPa. And MR elastography in Kolkata is available at Tata Medical Center, and they give very good reports. And even MRI PDFF, it is not available anywhere else. So if any other center is saying that we can do MR elastography at present, other hospitals are not doing it. So this is what a fibrosis assessment with fibroscan is done. It takes hardly 2 to 3 minutes, because as you can see, the probe is there, and this probe actually, it takes 10 readings. So a person has to do it. But, this is completely painless, but the patient has to be fasting for at least a minimum of 4 hours before you do this test. And this is what the report of fibroscan looks like. So a normal in a NAFLD patient, if you see, is around 6 to 6.5, the blue area. So this is around 6 to 6.5. As it goes up here, the higher the reading is, the patient has cirrhosis. So usually we tend to see more NAFLD patients. Alcohol obviously is also there, but our NAFLD patients, we try to keep their this fibroscan, the fibrosis report, less than 6. Steatosis can also be assessed by the FibroScan with the same machine that is measured in dB per meter. Normal readings are between 230 to 250, and those are called S0 because that is 0 to 5% of your liver cells having fat in it. And if the reading goes up, we say S1, S2, or S3. S3 means 67 to 100% of your liver cells have fat in them. So that gives the estimation to the patient also as to how much fat they have in the liver. MR elastography, as you can see in a normal healthy individual, looks like this. And if a person has grade 4 fibrosis, you can see a lot more yellows and reds are there in that, MR elastography. Then drugs. Weight loss is the most important. I mean, before we even talk about pharmacological therapy, you have to spend that time in the clinic and tell your patient that they have to lose their weight. That is the first and foremost important thing in any NAFLD patients. You might not have to give any drugs at all. So weight loss is combination of hypocaloric diet with increased physical activity will decrease your hepatic steatosis. Regular exercise will decrease your insulin resistance, decrease your cardiovascular risk, and target weight loss has to be 10% in six months. So if you are reducing, if the patient is managing to reduce 5%, then they're reducing the steatosis. But a weight loss of 10% is needed to decrease necroinflammation in the liver. So different, trials have been done in our country and all over the world. And if you can see, Dr. Duseja is from PGI Chandigarh. So all of them have shown that if the patient is on a hypocaloric diet and if the patients are exercising also, they can actually lose a lot of weight. And different studies have shown the same results. So that is why it's important that we emphasize this to our patients. Also, drugs have been, tested in the clinical trials. A lot of drugs have been tested, and you have metformin, pioglitazone, vitamin E, ursodeoxycholic acid, pentoxifylate, and atorvastatin. So if you look at the drugs, metformin is not recommended only for fatty liver per se, but a lot of our patients have insulin resistance. So just 2 weeks ago, we had the NAFLD conclave in India, in Delhi. And Dr. Arun Sanyal, he's a pioneer in this all over the world. He's a world expert. He was saying that if you have insulin resistance in the patient, even if it does not improve this liver histology, because it improves your insulin resistance, you must start your patients on metformin. Ursodeoxycholic acid is not recommended because though it normalizes AST-ALT ratio, but it does nothing to the inflammation and the fibrosis. Pioglitazone and vitamin E, I will talk about it in the PREVENCE trial. It's most useful, recommended for non-diabetic patients. But to say that Dr. Sanyal, who's actually done the PREVENCE trial, is now using vitamin A for his diabetic patients also. And the dose of vitamin E in the PREVENCE trial had come out to be 800 international units per day for 96 weeks, with improved liver histology. But obviously, the caution of prostatic cancer is there in the men. But they are using 400 international units per day and getting the same results because very few patients can tolerate 800 international units per day. Other drugs we are using, obviously, I've talked about pioglitazone. It does not decrease inflammation and fibrosis. But in the secondary outcomes of the PREVENCE trial, which I'll just talk about, insulin resistance does become better. But then there's worsening of weight gain, edema, and worsening cardiac failure. So that is why this drug is not very commonly used. You have the GLP-1 agonists, which our endocrine friends are using. A glucagon-like peptide 1, semaglutide and liraglutide have become very popular for our NASH patients, especially because they both help the patient to lose weight, as well as the sugar is very well controlled. Semaglutide also has an oral preparation now. But the problem with these are that the patients get a lot of nausea, vomiting, as well as postprandial, they get a lot of bloating. So very few patients can tolerate the oral variety because you have to give higher doses every day. Patients probably tolerate the injectable variety once a week better. Then you have the SGLT2 LT2 inhibitors, the sodium glucose co-transporter 2 inhibitors. You have the TAPA, CADA, and the empagliflozin. These drugs are obviously used by the endocrine doctors a lot, but these have shown to have great improvement by helping in weight loss, in controlling sugar, insulin resistance in these patients, and the liver has become much better. The NASH and the fibrosis has become much better after the patients have been started on this. These have not entered our the guidelines all over the world, whether it's ASLD guidelines or APSL guidelines have not entered, but clinically we have started using this drug. So the last two drugs are helping to reduce weight along with diet and exercise. It is very important whether your diabetic patients are doing the diet or exercise or not. But in our NASH patients, we have to tell them that unless they reduce their weight, and unless they go on a diet, they will only get temporary relief, and these drugs will not cause them to huge they will not help them with huge weight losses. The weight losses will only come in with exercise and diet. So it does improve insulin resistance, sugar levels, and NASH. I just want to talk about PIVIN study because our vitamin E manufacturer is our sponsor today. So PIVIN study was done by Dr. Arun Salyal, who's actually an Indian and is now lives in US. He used pioglitazone, vitamin E, and placebo for 96 weeks, and he took patients with NASH but without diabetes, cirrhosis, or Hep C, or heart failure, and limited alcohol intake. And he divided the patients into 3 groups. And what he found was the primary outcome was 43% patients of vitamin E versus placebo had improvement with steatosis, lobular inflammation, hepatocellular ballooning, and fibrosis. And the PIO group, they found 34% patients had improvement versus 19% in the placebo group. And the secondary outcomes was reduction in the vitamin E group in the SGOT, SGPT, and they in the PIO group, they also found improvement in the insulin resistance, but there was a weight increase which did not improve even after stopping the drug. So that is why pioglitazone is not very popular. And the conclusion was that vitamin A was superior to placebo in adults with NASH, but without diabetes. And just to add to that, nowadays vitamin E is being used in patients with diabetes also, because they have found that it does help them with their NASH also. And pioglitazone may have a role in treating, but long-term safety has not been established. So we are a bit wary about using pioglitazone in our patients. Now, pentoxifylline is a drug which has been there for a very long time, and pentoxifylline was initially used for alcoholic hepatitis. It is mainly alpha TNF, this thing inhibitor, and it is involved in the pathogenesis of NASH. So a lot of studies have been done, and they have been shown to improve your liver function test. Steatosis and lobular inflammation is reduced, and reduction in fibrosis stage also has been seen in the previous study. And nowadays, because of lack of medicine and expensive medicine, a lot of our patients cannot afford expensive medicine. We are giving pentoxifylline to a lot of our patients, as well as our cirrhotic patients, because even cirrhotic patients, if you see what the reading is before, if you give them pentoxifylline, even though they are not drinking any alcohol, they have a shift in their fibrosis levels on fibroscans. So now we'll talk about saroglitazole, which again endocrine friends have been using for a very long time. Research molecule of Zydus. First research molecule coming out of India, and clinical trials are being done in US by Dr. Arun Sanyal. And it has been approved in India for NASH also, though it was already approved for diabetes and dyslipidemia. Now it has been approved for NASH. It is a dual PPAR, agonist, which means a perioxisome proliferator activated receptor, and it has an alpha and gamma component to it. Alpha reduces your blood triglyceride level and HDL-C cholesterol. Gamma improves your insulin resistance, so lowers blood sugar levels. And it has been shown to decrease fibrosis and steatosis in a NASH patients. Obeticholic acid was a new drug on the block, but unfortunately it has not been approved by, in our country as well as by FDA, because though if it's an FXR agonist, it has a lot of beneficial effects on the liver, but the problem is that it has pruritus, increased cholesterol, and decreased HDL. So for this reason, it is not yet in the guidelines all over the world. The Flint trial was the most famous Flint trial has been done, where they have shown that in the primary endpoints, the DAS reduced by 2 points, and 45% patients actually had improvement versus 25% in the other arm. Versus placebo, and steatosis, lobular inflammation, hepatocellular ballooning all became better. And in the secondary endpoints, NASH resolution actually was seen, but it has not been approved because of the side effects. Then all our patients with NASH have to be vaccinated against hepatitis A and B. You must check hepatitis B surface antigen before even thinking of vaccinating your patients. Please do not do any blind vaccinations. If the patient already says that I've been vaccinated, please check for hepatitis B surface antigen antibodies. So you have to check for the surface antibody. If your level is 10 ml international units, 10 milli international units or higher, then that means your patient is already vaccinated. If it's lower than that, then please restart vaccination and please complete the vaccination again. And again, also your hepatitis A has to be done. There are 2 doses only to hepatitis A, whether there are 3 doses for hepatitis B. Fatty liver treatment, it is again In US, one of the three top causes of liver transplant. First cause, is hepatitis C, but unfortunately in India, NASH is becoming the top cause of liver transplant in our country. It's not anymore hepatitis B or C, which was, I think, 5 years ago. Now, NASH is the top cause of liver transplant. If you see in India, it's 30 lakhs per transplant. And this is usually, you do not get cadaveric liver, so you have to ask a relative to donate, which is live donor related donor transplant. US is around 3 crores, UK 1.2 to 1.5 crores, in Singapore 75 lakhs. So how expensive this liver transplant is. So it is very important that we take it seriously as doctors, and we make sure that our patients and their relatives take it seriously. NAFLD and NASH has become very common in India, more so in our country because we are the diabetic capital in the world. It is a common cause of liver transplant. We have to think about it in every single patient we see, even for acidity or gas formation or Crohn's for that matter. If they're obese, hypertensive, diabetic, and they have ischemic heart disease, investigate please further. If your patient has an ultrasound abdomen which shows fatty liver, please do not tell the patient nothing to worry about. Encourage the patient to lose weight. So we have to decrease the calories in diet. Even if we have to get a dietitian to sit and talk to them, give them an exercise program, see what they are most happy doing. If they want to go and play a game or a sport, or they want to walk, counsel regularly, and you make sure that your patients are following up you in the clinic regularly. We have to treat the dyslipidemia with statins, even if they have abnormal liver function tests, because it's not going to harm them at all. Then the drugs to use are vitamin E, pentoxifylline, seroglitazole, metformin, the GLP-1 agonists, and your SGLT2 inhibitors are all the different drugs in different patients which we can use. Ursodeoxycholic deoxycholic acid we do not usually use. That only normalizes the liver function test. But if at all we have to use it only to normalize the liver function test, you have to use 15 milligrams per kilo body weight. Fibroscan is very, very affordable in our country. So please refer. In my chamber, I can do it for 1,000 rupees every month. I have a machine coming in. Encourage patients not to drink alcohol or to decrease the amount. So we have to take a very detailed alcohol history, because patients will keep telling you, I don't drink alcohol much, I don't drink alcohol, and you'll find they're overdosing of the alcohol amount also. So vaccinate all your patients against hepatitis A and B. If they're cirrhotic, every 6 months they have to have an ultrasound abdomen and a alpha fetoprotein. If you're worried if the alpha fetoprotein starts rising, we are nowadays doing a triple phase MRI of liver, which catches your HCC much earlier than even a CT scan triple phase. We have to work as a team. NASH or NAFLD is not a disease which a liver doctor has to be looking after by themselves. Most of our patients are diabetics, and they also have dyslipidemias and hypertension. So we have to work together as a team, hepatologists, endocrinologists, and cardiologists, because all your cardiovascular patients who have ischemic heart disease also tend to have diabetes, also tend to have NASH. So remember, NASH patients are not dying nowadays from diabetic complications, because our diabetic doctors are doing a great job at looking after the complications. They're now dying from cardiovascular events or liver-related deaths, which is your cirrhotics. Please refer our patients, to transplant centers if they're sick cirrhotics. Thank you.
Thank you. Hello.
Hello. Yes, Dr. Amalda. Yes.
Thank you.
Thank you.
Thank you very much, Dr. Kedia. It's a wonderful presentation, and particularly mentioning how can we detect the disease earlier and embark on the treatment. And you nicely discussed the pathology and the management right. Now, just before may I take the opportunity to ask you?
Yes.
Because in the FLD,
yes,
due to diabetes, it is not difficult to treat because the primary factor is obesity.
Yes.
If somebody is obese and impaired fasting glucose diabetes, it is not difficult to treat. But certainly, it will be very difficult when you come across some lean people with non-alcoholic fatty liver disease. So can you just comment on
Dr.
this?
Sinha, those patients are very few. We do have lean NASH patients, but those people are very few in number. Majority of your patients are obese and overweight. You also know that you'll have that odd patient who has diabetes and they are lean patients. So in our practice also, out of, if I see 50 patients who are overweight and who have NAFLD, there will be only probably one patient who's lean and who's got NASH. But saying that they do have some sort of a defect in metabolism, some sort of a defect in their, for which they have more fatty acids and triglycerides going into the liver. And also if a normal patient starves a lot or suddenly does not eat or has malnourishment, they also get, NASH or NAFLD. So these patients, because of starvation, also can get lean NASH. So we have to make sure that our patients who are the lean NASH patients are not, have not gone through malnourishment because of a disease or, starvation. In the villages, we find a lot of these patients, especially because Dr. Abhijit Chaudhary in Kolkata has done a lot of studies on the population base. And in the villages, he's found a lot of lean NASH. And I think a lot of these patients are patients who are not getting proper amount of nourishment, or they have deficiencies of some, basic nutrients. So that is a separate, talk altogether. But those patients usually do not tend to have diabetes. I mean, you can probably better, tell us about it. But I think that those patients do not tend to have diabetes.
What I was thinking, if my primary factor in the NFLD is the triglyceride.
Yes.
You triglyceride steatosis. So you injure the hepatocyte with the triglyceride. So if you can block the triglyceride, even in the thin person, say drugs like saroglitazole, will that be helpful?
It should be helpful, because even even statin should do that work, na? So if your triglyceride levels are very high, if your patients have high triglyceride levels, so we have to first check in the lean NASH patient whether they even have low, high triglyceride levels. So if you block that, then obviously it's going to help. So saroglitazole can help. Even your fenofibrate group, that should also be able to help you.
Okay, thank you. And I'll leave it to the audience.
Dr. Kedia, I have got one question.
Yes.
So the thing is that you also appreciated that in the prevalence study of the NASH in India,
yes,
there is a regional difference. In South India, in Tamil Nadu and Maharashtra, particularly not Maharashtra, in South India, Tamil Nadu, the prevalence of the NASH is highest. So do you have any idea why the South India has got a highest NASH?
See, we have not been able to figure that out. I think there's a lot of genetic play to this also, because their food is not any richer than North India. And now if actually we have talked about this in our conferences, and I think these studies have been done by big centers. They've been done by big academic centers only. So it's not population-based studies, most of these studies. So it depends. It's a lot of tertiary referral factors also which come in there. Patients who are coming to your hospitals. So that is, I think that is the reason. I don't think population-based wise, if you see, I don't think this is true. But I think it is most that, North India and South India, the centers are less in North India, academic centers. They're more in South India. So when we look at the studies which are coming out, in East India, we only get studies coming out from Kolkata. So that's the problem, that South India has a lot more academic centers. And so the results we get from there is more, referral based. So it's biased because of the tertiary referral bias. And North India, again, you have only a few centers.
It is not true representative.
It's not a true representative. It's basically the number of centers who are doing the trials.
And another question is that even I think I have seen that the Dr. Sarin is used to advocate that black coffee is one of the things which can reduce NASH.
Yes, so we are recommending that you can drink up to three cups of black coffee a day, but not more than that, because then it starts having side effects. Yeah, so I think it works as an antioxidant. That's how it works. Because nowadays they're saying that even tea drinkers, but not your typical milk boiling and milk and milk tea, not milk tea, but liquor tea. In the last conference I attended, they said not only coffee drinkers, but even tea drinkers will have the same effect as coffee. Coffee works better than tea. But if somebody is drinking liquor tea without sugar, without milk, that also has the same effect on NASH, because it works as an antioxidant. And obviously in the gut, see, all these NASH patients, they are obese, they have a leaky gut. So a lot of bacterial, antigens and everything are going into the liver also. So I think at the gut level also, coffee and tea works at the gut level also to improve the gut quality, and then the bacteria improves. And so I think there's a lot of reasons to it. It is not simply antioxidant. It works at the leaky gut level also, to the microbiota of the gut, because in NASH and NAFLD, it has been found that the patients have a very dysbiosis. So that means the gut microbes are also very effective. They don't have normal gut microbiota. So they have actually done studies whereby they have taken from a healthy individual, they've taken the gut microbiota and they have done FMTs to the NASH patients, and those patients have actually improved. The NASH has gone away because the gut microbiota has changed. And in the mice studies, they have actually taken vice versa. They've put the microbiota of obese mice who have NASH. They put it to the lean mice, and those lean mice have actually got NAFLD and NASH. So the gut microbiota is becoming a very important. It has a very important role in NASH and NAFLD. But to actually bring it down clinically and to start doing FMTs for NASH and NAFLD is not obviously being used yet. But yes, they're using it in Crohn's disease. In some centers in the country have started using it. But in NAFLD and NASH, they're not using it. But the studies have shown that the gut microbiota is very, very important in NASH and NAFLD patients also.
Thank you. I must say that it's an excellent session, the deliberation on the NASH.
Can I have a comment?
Yeah, thank you very much.
Thank you, Dr. Chakraborty.
I have a comment.
Yes, Dr. Ray.
First of all, regarding alcohol.
Deepika Ji.
Yes.
Sorry, can I just quickly finish? Or do you want to say, Devmallu, you carry on with yours?
No, Dr. Ray, you finished? Then...
Okay. Now, first of all, the alcohol.
Yes.
A lot of people doesn't admit, as you know, but I personally felt that gamma GT level, which is gamma, is more sensitive to alcohol.
Yes.
I disproportionately raise gamma GT, that raise a question.
Absolutely.
Secondly, I think the level of alcohol drinking is done for convenience by the Western world in particular, because this is a socially acceptable habit. But I don't think we are here to drink any amount of alcohol. So for men 14, women 10, why this kind of, I've never understood during my stay in the West as well as here. So
now in India, we are telling people that no amount of alcohol is safe. No amount of alcohol is safe for your liver or for your brain.
Exactly. So that kind of statement is really not necessary anymore, because they should not drink. So at least if you say no, then you will drink 5.
No, at least for my patients who have NAFLD or NASH, I actually write in block letters, no alcohol.
Absolutely. Is that true?
I write it. I mean, cirrhotic patients who cannot drink.
Dr. Kedia, also for the heart, it's a myth that alcohol is good for heart. It is not actually.
No, it's not.
It's a myth actually, which a lot of people, a lot of papers have come out from Italy that red wine is good for heart.
Yeah, and that is what the patients quote, saying that we are drinking it to protect our heart.
Yeah, absolutely. Dr. Sannal, you wanted to say something?
Demalio, you want to say something? Yes.
The few observations. Yeah, one is, that, if we go by BMI, we are likely to miss a lot of patients. We have published data that central obesity by measuring the waist circumference is more likely, because we are more centrally obese, to catch more NASH population.
Yes, I've written that.
The current guidelines suggest GLP-1 also as a good agent for NASH with regards to inflammation as well.
Yes, we are using this.
Mainly with Flozin, it is mainly obesity. Flozin, it is mainly decreasing the liver fat, but inflammation is mainly with GLP-1.
Yes,
and finally, one question to Deepika Di is that which of the fibrosis scores, the FIB4 or the others, would you prefer in our population? Any data?
Easily available in the clinic is, we can do APRIs and we can do the NAFLD fibrosis score, because you can just do it on the on your phone immediately, because these are all online scores. Some of the other scores, you have to send blood to the labs and they're very expensive. Some labs are doing it, they're very expensive. Most of our patients cannot afford it. So the easiest to do is the APRI, and because you have the patient's AST level and the platelet level, etc. And the online NAFLD fibrosis score, which we just have to log on, on your phone and just put in the details and you get the score. So we tend to use this in the clinic.
Yeah.
Just one point I'd like to mention. You sometimes come across isolated rise of ALT, and this is called cryptogenic ALT rise. So this group of people should undergo ultrasound and fibroscan examination with a view to excluding the possibility of non-alcoholic fatty liver plus minus NAS.
Yes, I agree with you. I mean, patients, either they're taking a new drug which can cause this rise in, LFT, but if they have not started any new drugs, then we have to make sure that we check out their hemoglobin A1Cs to make sure they're not like, diabetic or, dyslipidemic, and then obviously do the ultrasound and the fibrosis scan. Shekhar is going to say something. Dr. Chakraborty, you need to unmute yourself. You've raised your hand.
No. It's I think incidentally it got ticked.
Okay.
Only compliments that fantastic lecture.
Thank you very much. Thank you.
Can I ask a final question?
Yes, Dr. Ray.
You mentioned about saroglitazole, quite rightly so, and mentioned about the triglyceride level, and also there is about fibrosis and steatosis reduction. Is there any more specific data about this? How much of this does over how long period?
See, I mean, initially they have reports. Dr. Sanyal has done his studies for 1 year in US. We have studies for like 2 to 3 years. So what he's saying is that if you stop the drug, saroglitazole, and if your patient is not exercising and losing weight, then your effect goes away.
While the patient is on the drug, how much reduction from F4 to F3 of F3 to F2?
Oh, usually it can be at least 2 stages. So I have seen my patients go from F4 to F2 on this drug. But I have also made them exercise and make sure that we have altered their drug also, their diet also.
Unfortunately, we cannot monitor their exercise. They might say,
so exercise and the diet we cannot monitor. But see, we have to start making sure. I mean, since a lot of our friends in this webinar today are endocrinologists, we have to make sure that we tell our patients that you might have liver disease and you need to take it seriously. And so ultrasounds have to be ordered by them, because the patients are their patients. So they have to order liver function tests and ultrasounds, because if we don't catch them early, they are coming to us, liver specialists or gastroenterologists by the time they're developing cirrhosis. That is too late. So we want to catch them early so that we can, institute whatever corrective measures we have to take. And, some diabetics might not take it seriously if they have diabetes, because the sugar, they can still control. They're not scared of it anymore. But if you tell them that if you don't take care of your liver and you're going to get cirrhosis of liver and you need a liver transplant in future, then sometimes the patient takes their, diabetes also seriously and the obesity also seriously. So I think as a collective, all the doctors collectively have to work with each patient, like endocrinologists and, the cardiologists and our, hepatologists, to make sure that each patient understands that everything is linked to each other. So if they don't take care of their weight and their diet, the diabetes will not get well controlled, and they might get very significant fibrosis and cirrhosis in future. And obviously cardiovascular risk, which Vinayak is going to agree with me, that is what kills them. These will kill them later on. They're dying much earlier because of this, because of cardiovascular risks. So I'm sure Vinayak sees them much earlier than we get to see them.
Yeah, the other thing, Deepika, is actually that if the consulting rooms of the doctors are side by side, that helps the patient too.
Yes.
Devmalo and myself, we sit side by side. It helps the patient.
Cool. That helps really a lot. No, but my request to all the doctors who, see any diabetic patient is to do a liver function test on this patient and at least to do an ultrasound upper abdomen. At least if they get the minimum of this done, then, we can catch all our NASH NAFLD patients much earlier.
Deepika, annual screening of diabetic patient includes LFT for a long time. It's nothing new.
But I think they also need to do an ultrasound upper abdomen, because you might have You will have fat in the liver, and sometimes patients do not have an abnormal liver function test.
I think I also strongly believe that many of the endocrinologists do not do the ultrasound as a routine, which doesn't cost a lot of money, but they have to just write it. So I think I would also fully support this view that everybody who is a diabetic should have an ultrasound and liver function test.
And I think the same goes with Vinayak. I think you should ask all your patients also who are hypertensive
we do that actually. We do that, Deepika, that a lot of my patients who undergo actually the health checkups, they do have the upper abdominal ultrasound.
Yes, exactly.
How much does the cholesterol, high cholesterol, correlate with the non-alcoholic liver disease, fatty liver? I mean, how much does it correlate?
See, I see a lot of patients who will only have an isolated high cholesterol with mild obesity, and they have significant amount of, NASH. Even abnormal liver function test for that matter. So if you, and even the high triglycerides, I mean, my friend Dr. Anjan Sevatia keeps telling me, high triglyceride level, you don't have to treat because it does nothing to, decrease the risk of cardiovascular problems.
Does it have a linear correlation?
I think so, because I have seen that if a patient comes in with high triglyceride level, they will definitely have, I'm talking about 200, 300 range, 300 and above. And they will definitely have abnormal liver function test and fatty liver. And the moment you just treat their triglyceride levels, the liver function test normalizes immediately within like 3 months. But I mean, obviously, a lot of these patients are not obese also, by the way. They are the familial patients, the familial hyperdyslipidemia patients who have triglycerides.
I think in India, we don't need to be obese to be metabolically abnormal.
Yes,
very, very
because
we
you can see
need to be obese.
Because you have our obesity levels, and this thing is happening at overweight is at 24 BMI.
22. Actually, diabetes is 22 now. It's 22.5. Anyway,
can I raise one more question? I think we're getting too late, of course. The fatty liver grades and FibroScan grade, is it well correlated or not?
No, they don't correlate.
Yeah, that's right. That's also in my experience.
No, it does not correlate. You'll have a stage 3, grade 3 fatty liver here, and you'll see something. And the worrying bit is also that on ultrasounds, a lot of patients are branded as grade 2 or grade 3 fatty liver. But when you do the FibroScan, they're already cirrhotics.
Yep, that's right.
A lot of our patients, we see that.
I mean, although we should do ultrasound, but we shouldn't stop there.
Just at the end, I want to add something.
Yes.
When you see patients with isolated triglyceridemia,
yes,
you treat with surrogate or dipagliflozin or drug. That will
that is not the first drug. Surrogate is.
Just a minute. That will bring down the triglyceride level, and also has got an impact on the management of NASH.
Yes, but are we talking about patients who are obese, or are we talking about patients who are not obese?
Doesn't matter. Doesn't matter. If you see somebody has got an isolated triglyceridemia and HDL probably a bit low and normal total cholesterol and LDL, you treat with lipagliflozin, and you may do an ultrasound of the abdomen. You see some fatty changes. If you see with the drug called surrogate, you not only reduce you not only get the beneficial effects of the lipid triglyceride lowering effect, but also you get the beneficial effect on the management.
But then you're also reducing the glucose levels, aren't you?
No. They have an impact on the triglyceride on its own.
But they also have an impact on the sugar levels. So if your hemoglobin A1C is already 5 point something to start with, why do you want to lower it further?
No. Lipagliflozin does not cause hypoglycemia.
It does not cause hypoglycemia, but you're just lowering your hemoglobin A1C further, isn't it?
No. The thing is that, Deepika, my comment is that, am I audible?
Yes, you are.
My comment is that the saroglitazar reduces the HbA1c level less than 0.4%. It has been studied that it is around 0.3% or 0.2% like this. It hasn't crossed. And any drug which has to be established as an anti-diabetic drug must reduce the HbA1c level more than 0.4%.
Okay.
So therefore, it is not an anti-diabetic drug till today. It reduces the blood sugar, but it doesn't cause hypoglycemia.
Yeah,
so if
that's
you even you in a normal glycemic patients, if you give saroglitazar, it doesn't cause hypoglycemia.
Hypoglycemia, yes,
but
that we know.
My focus of discussion to other side. You see that what Dr. Sinha was talking about, just any hypertriglyceridemia in a patient, if you do saroglitazar, the problem is that we will reduce the triglyceride. But no, only reducing triglyceride is not enough for the patient. That is important, because the NASH patients, they accumulate the fat in the liver and they develop a low-grade inflammation. That inflammation ultimately leads to the chronic inflammation, leading to NASH, and followed by, as a result of chronic inflammation, there is development of the fibrosis. The problem is that the saroglitazar using, just reducing the triglyceride doesn't prevent the inflammation. So therefore, we have to have a reduction, and we have to have the exercise, and the exercise and as well as the diet control reduces the fat, and that fat leads to reductions of the inflammation.
But Dr. Chakraborty, I understand what you're saying, but the problem is when to stop. So Dr. Sanyal was also not clear on this, who was doing it in NASH, saroglitazar in NASH. He was saying it's becoming like a lifestyle drug. That means if you don't reduce your weight and you don't reduce your, basically your weight, then, and if you don't alter your diet, you have to take this drug lifelong.
This drug doesn't prevent the progression. This drug only reduces the triglyceride level.
Yeah, but then when to stop this drug?
Inflammation, you have, the patient has to do the exercise and diet.
That's what I'm saying, that you have to have that also in
lifestyle modification is the number one, because unless there is lifestyle modification, the fatty accumulation and what we call it a fatty liver, that cannot be prevented, because you see the fat cells doesn't have the blood vessels. When it accumulates in the liver cells or in the adipose tissue, they gradually swell up and they don't have the blood cells. So blood supply. So gradually the blood supply of the hepatocytes are getting cut down. So the cells die. Once the cells die, the lot of macrophages are coming to engulf the cells. And when they engulf the hepatocytes and as well as the fatty cells, they liberate a lot of cytokines, and that invite the inflammation. That is the main problem. So once inflammation sets in, it goes on progressing towards the chronic inflammation. So unless we can reduce the fatty accumulation in the liver by diet control and exercise, these hepatocytes will bound to die. And when they die, they will invite inflammation, because they will attract the macrophages and other polymorphs and lymphocytes. This is a very low grade inflammation goes.
Yes.
So therefore,
Deepika, I just wanted to, okay, yeah, doctor.
Reducing the triglyceride is not enough for the NASH. The patient should have a regular exercise to reduce the body weight as well as the diet control, so that the fatty accumulation in the liver reduced, and then the process can be reversed.
Yes, Dr. Chakraborty, I totally agree with you, but it's completely patient to patient. We have to sort this out.
Deepika, I wanted to ask a question. At what stage of fatty liver disease on ultrasound do you refer as a cardiologist to a gastroenterologist? At what stage?
I think if they have even grade 1, I would want to see those patients, because we like to do a fibroscan. Like I just told you that your grading on ultrasound does not correlate with the fibrosis on the fibroscan and the steatosis we find. So that is why we need to see any patient who has grade 1, grade 2, or grade 3. So even grade 1s, I would like to see them. If we do a fibroscan and they have a completely normal fibroscan, then at least we are all right. Okay, you do not have the significant liver disease. Your liver function test is normal, and you do not need to come back and see us, very soon. But if they have any amount of fatty liver, I would want to see them, because you will be amazed to see that on fibroscans, they have significant fibrosis in the livers.
So for every abnormal ultrasound, you are actually doing a fibroscan for every patient?
Yes, I do.
Okay.
Because what we do is I have a machine coming to my chamber once a month. See, outside it's quite expensive. It costs around 4,000 to 5,000 rupees in the normal
yes, exactly.
labs.
Yeah.
But in my chamber, I can do it for 1,000 rupees because I get a machine coming every month. So that is why I just collect all my patients. If they can't come that month, they come the next month, and they just have to be 4 hours fasting. So even if you want your patients to come to my chamber, they don't have to come and see me at all. They can just put their names. I can give you my chamber number. They can just give your name. They give their names, and we just tell them come 4 hours fasting. That's all.
So basically, if your fibroscan is normal, then you are actually through for that moment.
At least for the next 6 months, 1 year, we are okay that the livers are all right. And if the liver function test is also normal.
Yeah, okay.
Because even the fibroscan has its limitation, you see. At times, fibroscan also has a limitation. So your liver function test also has to be normal. And your fibroscan is normal. And your ultrasound shows mild fatty changes. If your fibroscan shows normal levels and your liver, your ultrasound shows grade 3, then that means there's an error there, because even fibroscans are not foolproof. So then we might have to do MR elastography for that for those patients.
Because I think this is a very underdiagnosed condition, and which can give to life-threatening problems later on.
That is what is happening. That is what is happening. See, the patients are not dying because of diabetes nowadays. They're dying because of cardiovascular risk. So you are seeing them much early in the 30s and 40s with significant, heart problems. And we are seeing them later on, but by the time we see them, they already have cirrhosis of liver. So that's the problem.
Okay. Thank you very much.
Okay.
Thank you
very much.
Thanks.
Thank you.
It's a wonderful and vivid presentation. You went to the depth of the problem and made it simple with regards to the diagnosis and management.
Thank you, Dr. Sinha. Thank you.
Okay. Thank you, everyone. And thank you, Dr. Sujay Roy Chaudhary, to give the vote of thanks. Please, Dr. Roy Chaudhary.
Yes. Good evening, everyone. Am I audible?
Yes.
Yeah, you are.
Yes. I think
you are audible.
I think all of you will agree that we had an excellent scientific discourse today on 3 important aspects of medicine. Initially, Dr. Deepika Kedia told us about Crohn's disease. She talked about the pitfalls in the diagnosis and management of Crohn's disease. And she discussed the important possibilities and how to differentiate it from the tuberculosis, which is very common, differentiating points from the Crohn's. Then we had a very interesting talk by Dr. Shekhar Chakraborty, who spoke to us about insulin co-formulation. And he mentioned the important need for he talked about secondary OHA failure and to go for early insulinization, and why newer insulins or designer insulins have replaced the older insulins, and the important advantages and pros and cons. And the last talk initiated a lot of discussion, the management of non-NFLD. And Dr. Kedia also talked a lot, very well on this topic. She told us about the preventive aspects and to catch them early as the slogan, as she said. And most of you agree that lifestyle modification is the most important aspect in controlling obesity, which is very important in increasing our country by leaps and bounds. That is also so important to prevent this lifestyle disease, which can lead to fatal consequences. So on the whole, we had a very nice scientific disposition. I must thank all the speakers, especially Dr. Deepika Kedia for her 2 presentations, and Dr. Shekhar Chakraborty. Also, I would like to propose a vote of thanks to the sponsors. I think it was Valveri for the Fatty Liver Symposium, Novo for the Diabetic Symposium, and the first symposium was sponsored by Sun Pharma, I think, Cygnus Division.
Yes.
So all 3 of them deserve accolades for this excellent presentation. And all good things come to an end, so I'd like to close the session by proposing the vote of thanks, and I hope you all enjoyed this session. Thank you.
Before we close, can I just
say all chairpersons?
Thank you.
All the chairpersons.
I think it is a very rare occasion when 2 doctors meet on the same day. So Shuja and myself met twice today. One physical in the morning and online in the afternoon.
Yes, it was a good day.
I think before we close, can I just mention that we intend to continue this webinar as well as CME in the next coming months. So we'll be in touch very soon with another program within a month or so, or even before. So we will let you know in due course after discussion with our core committee members. We'll give you the next agenda. Okay. Thank you very much for your attention and perseverance for the next 3 hours. We had a very good meeting, and for the better one next time. Okay.
Thank you. Thank you very much.
Thank you.